sir, very much fine. Spending time with family and kids, sir. No practice, no.
For spending time with the family, you need a lot of practice.
So off late, slowly people are started coming to the hospital, but there are absolutely no fear to go to malls, restaurants. Traffic jams are there, but only into the hospital they say it's corona. When they come into hospital, they get corona. The fear of corona only in the hospital. Good morning, sir. Somsekhar, sir.
Hi.
Everybody, good morning.
Definitely, traffic is improving. You are getting blocks, jams. Yeah.
Yes. The only reason traffic is little less is because schools and colleges are not there. Apart from that, and all the IT industries have given work from home. So many people have gone to their respective cities. They vacated their house. Almost 2 lakh houses are vacant in Bangalore.
Sir, we are live, sir.
Yeah.
Shall we start, sir? It's 9 o'clock.
Yes.
If you start at 9 o'clock in India, you're not an Indian.
Yeah, very right.
Okay, but let us try to be Indians today.
Sir, great, sir. Thanks. So,
Yes,
yeah, I'm just sharing my screen. Yeah. So, good morning, everyone. On behalf of Twin Cities Orthopedic Society, I would like to invite you all for today's webinar on primary total knee arthroplasty. So this is conducted by Twin Cities Orthopedic Society under the aegis of TOSA, and it is supported by Johnson's. So before I introduce the faculty, our Telangana Orthopedic Surgeons Association President, P. Sudhir Kumar is here. So we'll have a small welcome note followed by introduction of the faculty. So over to you, Sudhir.
Welcome to you all. Very good morning and a happy Sunday. On behalf of TOSA, it's a pleasure for me to welcome you all. It's been a lot of series of webinars from TOSA, and I thank Dr. Srinivas Kasha and Jansen and Dr. Somsekhar Reddy sir for organizing this webinar. I think it's very useful for all the youngsters and consultants also. It's on primary total knee orthoplasty, and all the big stalwarts are there here. They'll teach you how to go about. Thank you.
Thank you, Dr. Sudhir. So I am going to introduce our faculty who are there today. To start with, we have international speaker Dr. Ali Mehdi. So he is actually graduated from Osmania Medical College in 1994. Since 2007, he has been a consultant orthopedic surgeon at NHS Borders. He led quality improvement programs of ERAS, the first for a general hospital in Scotland in 2010. This led to his unit developing the quickest inpatient recovery for arthroplasty in Scotland. He is faculty member of Royal College of Surgeons of Edinburgh and convenes basic and advanced surgical courses for colleges, including the one which was conducted in Hyderabad last year. He has been delivering online training for medical educators, leadership development for doctors on behalf of College of University of Edinburgh. Welcome, Dr. Ali Mehdi.
Welcome.
And yeah, good morning. Next is our beloved Dr. A.V. Gurvareddy sir, one of the pioneers of joint replacement surgery in India. He is my guru. I have learned arthroplasty under him, and I think most of the arthroplasty surgeons in Telugu states are trained under him. And he has taught that orthopedics is not just cutting and stitching, but there is a compassionate angle in dealing with every patient. So most of the arthroplasty surgeons are directly or indirectly trained by him, and because of his vision, we have got advanced arthroplasty services in both Telugu states. Next, we have Dr. Sir, welcome you, sir. Honored to have you here. Next, we have Dr. J.V. Srinivas, who is a consultant arthroplasty and revision joint replacement surgeon from Aster RV Hospital, Bangalore. Very good academician and who loves teaching. Thank you, Dr. J.V. Srinivas, for accepting the invitation. We have Dr. Neelam Ramana Reddy. So he is going to join for the panel discussion. He has sent us a video. So I'm going to play because of he is in the periphery today. And we have Dr. Uday Krishna Maineni from KIMS Hospital, Secunderabad. And we have Sai Lakshman Anne from KIMS Hospital, Kundapur. And Jagan Mohan Reddy from SLG Hospitals, Hyderabad. And our Somashekar Reddy sir, and we have Chandrasekhar from Medical Hospital, Hyderabad. So we have got mixture of senior and contemporary practitioners. So hope you all enjoy today's meeting. And this is the program which is going to be. We have got 6 talks followed by panel discussion. So all the participants are requested to ask their questions in chat box, which is going to be on YouTube, and mention your name so that we can address the question, and mention the name of the speaker to whom you are asking the question. So instructions to speakers, please maintain time. We'll read out the questionnaire from the audience. Be ready to answer the questions. So without any delay, I would like to ask Dr. Chandrasekhar to take over and then start your talk.
Thank you very much, Srinivas. I'm just going to share my screen now.
Yeah, I'll stop sharing.
Before he starts, hello, Dr. Ali Mehdi. Good morning.
Hello, good morning.
Yeah, good. So I was there in England for 10 years. So it was a wonderful experience. I'm sure you are enjoying the same.
Privileged to talk to you. I've heard a lot of good things about you, sir.
Thank you so much. I said after Lady Diana died, I thought there was no more glamour in England. So I came back.
Chandrasekhar?
Can I start?
Yeah, you're on.
Okay. So good morning, everyone. Thank you very much, Dr. Srinivas and Dr. Somashekar Reddy, sir, for giving me this opportunity. I feel privileged to take part in this webinar. My topic for today is preoperative workup and planning for a successful total knee arthroplasty. As we all know, total knee arthroplasty is a very successful surgery, and it gives very good outcomes when it is done for a right indication in a correct patient. And a lot of preoperative planning goes into undertaking this procedure, and the ultimate success of total knee arthroplasty depends on how well you plan your surgery and how well you execute the plan. And choosing the correct patient is of utmost importance. And needless to say that the surgeon's ability to perform the surgery to the highest standard determines the ultimate outcome, and also providing the surgery in a safe environment is of utmost importance. Having said that, most of these patients who undergo a total knee arthroplasty do suffer with a lot of comorbidities, especially cardiac related complications. So it is very imperative that the patient undergoes a thorough cardiac evaluation preoperatively. And sometimes you can incidentally identify any cardiac related problems while the patient is being screened for a total knee arthroplasty. And according to this paper published in Lancet and from the NJR figures of England and Wales, there is a 0.2% risk of mortality following a total knee arthroplasty in the first 6 weeks after the procedure. And a lot of time, the main cause for the death in these patients are cardiac related complications. So the 45-day mortality of 0.2%, I think, is quite significant. And a thorough evaluation preoperatively would help avoid or minimize this postoperative complication which may happen in certain patients. And the other important aspect is that these patients who suffer with cardiac illnesses may be on anticoagulant therapies. And it is necessary that you take opinion from the cardiologist about the timing to stop these anticoagulants like clopidogrel, warfarin, or aspirin, because continuing these anticoagulant medications during the surgery may pose a risk of excessive bleeding and hematoma formation. And there are certain papers which have shown that even withholding these medications can pose certain risks with thrombosis. So you have to weigh the risks and benefits of withholding these anticoagulants prior to taking these patients for theaters. So a close liaison with the cardiologist is very, very important, and on timing of these timing to stop these anticoagulants and when to restart them. And throughout the surgery and postoperatively, they need to be maintained on alternative forms of anticoagulants and monitor their clotting profile continuously. We all know that uncontrolled diabetes mellitus poses a high risk of periprosthetic joint infection. This is an excellent guideline which is given by the American Academy of Orthopedic Surgeons about prevention and management of periprosthetic joint infections. And strict control of blood glucose levels, not only preoperatively, but perioperative period also is very, very important to reduce the chances of in periprosthetic joint infection. And any HbA1c more than 7.7 poses a twofold risk of periprosthetic joint infection, and it is necessary that you optimize the sugar levels before you can safely take the patient to theater. And sometimes these elderly patients do also suffer with problems with peripheral vasculature. So if you see a patient with a severely calcified popliteal vessel, like on the X-ray seen on the left side, then you have to plan out your surgery, because using a tourniquet in these patients can pose a higher risk. And also, if you are planning to do any excessive posterior soft tissue release intraoperatively, there is a higher chance of vascular injury. So you have to optimize their peripheral vascular status prior to taking them to theater. And if they have venous edema, then you have to avoid using a tourniquet in such patients. And if you see any foot ulcers in these patients, it is a relative contraindication to do a total knee arthroplasty until the ulcer heals completely, and most of the time they're associated with uncontrolled diabetes, so their sugar levels have to be optimized before they can be safely taken up to theater. And there is always a dilemma whether you should do a routine urinary screening for these patients preoperatively. This is an excellent systematic review and meta-analysis of around 663 papers, out of which they chose about 10 papers for review. And what they say is that asymptomatic bacteriuria does not pose any higher risk for prosthetic joint infection. It is only the symptomatic bacteriuria which poses a higher risk of PJI. So if it is an asymptomatic bacteriuria, I think you can safely take them for theater. But if the patient is symptomatic, they need to be treated with appropriate antibiotics. In this paper, they saw that patients who developed periprosthetic joint infection had a different organism to what they actually found out in their urine analysis. And a lot of these patients who undergo total knee arthroplasty may be having inflammatory arthropathy. And the surgeon is always faced with a dilemma whether to stop these medications or not. And a lot of these patients are already immunocompromised because of the rheumatoid arthritis itself. And these medications further compromise their immunity. So the American College of Rheumatology came up with a good guideline in 2017. And as per their guidelines, they say that it is safe to continue with the DMRDs like methotrexate, sulfasalazine, and HCQS. They can be safely continued because the risk of stopping these DMRDs in the perioperative period is far more than the risk of continuing with them. However, when it comes to biologic agents, they will have to be discontinued because of the higher chance of PJI in these patients. If somebody has severe SLE, then again, the medications may have to be continued because the risk of stopping them is far more than risk of continuing with them. In case of non-severe SLE, the medications can be discontinued. Suppose you see a patient with some psoriatic lesion in front of the knee. I think this poses a very high risk of periprosthetic joint infection. So these patients have to be carefully planned out, take a dermatology consultation, optimize the skin condition, and if possible, try to manage the arthritis conservatively rather than taking a risk with bad skin lesions in front, which come in the line of your incision. And the other patients who are at higher surgical risk are patients who are inflammatory arthropathies, post-cancer patients, and transplant patients. Again, these patients have to be optimized, and the risk-benefit ratio has to be weighed before they can be safely taken up for theater. And sometimes because of severe deformities in the leg, the patients may have been bedbound for a very long period. And these patients, when you take them up for theater for surgery, there is a chance of patients having chronic DVT. So it is imperative that you do a preoperative Doppler ultrasound scan to exclude DVT. And in liaison with the vascular surgeon, sometimes you may have to consider putting an IVC filters in these patients to reduce the chance of any DVT causing a pulmonary embolism and increased mortality. The other higher surgical risk patients are patients who have any mental illnesses. They may pose a higher risk of having chronic pain after the procedure. There can be issues with rehabilitation. These are the patients who may not be satisfied, especially who are depressed and who have psychiatric illnesses. So you need to get their psychiatric illness optimized. And if patient has Parkinsonism or any other spastic conditions, there's a higher risk of falls and complications. So neurology consultation in these patients is necessary to get their Parkinsonism under control. Having optimized the general condition of the patient, attention should be paid to the thorough clinical examination of the knee. The local skin condition has to be assessed for any abrasions or ulcerations. And if there is any, then you have to delay the surgery until they heal up completely. And sometimes the patients may have had multiple procedures in the past, so which leaves with multiple incisions. So you have to choose the most lateral of all these scars for a safe skin healing, because there's a higher chance of necrosis if you use the medial scar. And if there is any previous metalwork, then you have to get inflammatory markers preoperatively to exclude any infection. And also you have to plan out how you're going to remove the metalwork, whether in a staged manner or a simultaneous removal of metalwork. And you have to plan out what is the amount of bone defect which can be left after removal of the metalwork. And careful attention should be paid to the amount of coronal and sagittal plane deformity. That will help you decide how much of soft tissue release you're going to take, and then how much of bone cuts you're going to make. And the range of movement, again, I think the subsequent talks will be covering all this with the fixed flexion deformities and the varus and valgus deformities. And if patient has a relative quadriceps strength weakness, they will have a poorer outcome if you do a surgery without restoring the quadriceps strength. So in these patients, you may have to consider doing a preoperative physio to restore their quadriceps strength. And sometimes the patients may have a ipsilateral hip stiffness, in which case positioning the patient can be difficult. So you may have to optimize the hip condition prior to do a total knee arthroplasty, and assess your neurovascular status distally so that you can monitor it. And functional scoring system is always helpful to monitor their progress and also for research purposes. Suppose you see a patient with multiple pathologies. There's something called as musculoskeletal comorbidity index. So that has to be assessed. Sometimes patients with hip and spine pathology may manifest as knee pain. So in these patients, a careful clinical examination can avoid an unnecessary knee surgery. So if there is any hip or spine pathology, deal with the proximal joints first, and then deal with the knee problem. And it will be surprising to see that most of the times, dealing with the hip and spine problem may actually alleviate the knee pain. And with regards to bilateral pathology, again, it's a controversial thing whether to do a simultaneous staggered or a staged procedure. It, again, careful assessment of the patient's fitness for a simultaneous procedure has to be done. And if somebody has a severe flexion or varus deformity, doing a staged procedure may be difficult, because if you correct one knee, then patient may still be left not being able to walk properly. So again, assess the fitness, make sure that there is an informed consent before you can go do a simultaneous procedure. Irrespective of what sort of an implant you use, the ultimate technical goal for complete patient satisfaction is achieving a neutral mechanical alignment of the limb to within 3 degrees, restoration of the joint line, balancing the ligaments, and restoring the patellofemoral kinematics. And if you see somebody with a suspected infection, or if there is a neurogenic recurvatum or a deficient quadriceps mechanism, that's an absolute contraindication to do a total knee arthroplasty. Having thoroughly evaluated and optimized the patient, the next step is to get proper X-rays of the patient. And full-length radiographs are very, very helpful to plan your surgery. Standing AP and lateral views, and also skyline views. So I'll just briefly go through the steps of templating. The first step is to assess the mechanical axis of the limb. For beginners, I think templating will be helpful to plan out your surgery and understand the kinematics of the knee. So you take a full-length X-ray, draw the mechanical axis, and draw the anatomical axis from the along the intramedullary canal, and you determine what is the valgus cut angle. And typically it is between 5 and 7 degrees. If it is a taller individual, then your valgus angle will be slightly lesser. And if it is a short individual, then the valgus angle will be a little bit more. So depending on the valgus cut angle, you have to determine what is your distal femoral cut. And then you have to determine what is your proximal tibial cut. So in case of tibia, the anatomical axis and the mechanical axis are parallel to each other. And you have to determine what is the amount of tibia you're going to cut. If there is a severe flexion deformity, then you may have to go for additional femoral resection. And to balance it, you may have to go for an additional tibial cut if it is tight in both flexion and extension. So you plan out what is the amount of cuts you're going to make and what is the line of cut as well. And after having done that, you assess any bone defects and osteophytes. What is the amount of release you're going to do? And if there is any severe bone defect, plan out what are the implants you're going to get ready, like your stems and then the screws, etc. And sometimes you may need augments as well. And restoring the tibial slope is also important so that you can restore the kinematics better. Assess the patellar height. If there is a patella baja preoperatively, then the patient, the exposure of the knee can be difficult. So anticipate this difficulty preoperatively. If there is a patellar baja, you may have to go for an additional tibial resection so that you can elevate the joint line. And preoperatively assess the need for any lateral release, especially in case of a valgus knee. So assess the patellar shift or tilt preoperatively. And while determining the femoral size, make sure that you size it properly, restoring the posterior condylar offset and avoid anterior notching, and avoid any overstuffing of the knee, which may lead to stiffness in the knee. And while sizing the tibia, again, avoid overstuffing, because any overhang on the medial or lateral side can lead to irritation of the medial collateral ligament or the IT band laterally. So preoperatively have a plan as to what would be your sizes, what is the amount of cut you're going to make, and what amount of bone defects you have to deal with, and osteophytes which have to be released. With regards to perioperative considerations, it has been shown in a number of papers that regional anesthesia is far more safer with lesser complications as compared to general anesthesia. With regards to antibiotic and thromboprophylaxis, I'll show in the subsequent slides. Whether to use a tourniquet or not, it's an individual surgeon choice. But again, as I had alluded earlier, if there is any peripheral vascular problem, then it may be prudent to avoid any tourniquet. And pain management protocol, you should have your own institutional guideline, what sort of a pain management protocol you're going to use, like intraoperative nerve blocks and postoperative peripheral nerve blocks, adductor canal block, or any infiltration methods which you're going to use. And incision and approach, you should be thorough with your incision. What approach you're going to use does not make any difference as long as you are adhering to the strict guidelines and you're doing a good soft tissue dissection. And again, with regards to prosthesis, irrespective of what sort of prosthesis, you have to be familiar with particular implant. Balancing the knee and aligning the knee properly is of utmost importance. And preoperatively preempt any need for stems or augments. Antibiotic prophylaxis, any of the broad spectrum antibiotic is okay. In our institution, we use cefuroxime routinely, and the timing of the antibiotic is important. It has to be within half an hour of the incision time. That gives adequate antibiotic levels at the time of the procedure. And it has been shown time and again that there is no role for extended antibiotic prophylaxis in a clean surgery, and any antibiotic prophylaxis beyond 24 hours is not necessary. If somebody is allergic to any of the cephalosporins, you may consider giving clindamycin or vancomycin. The NICE guidelines state that the thromboprophylaxis regime can be any of these oral anticoagulants like aspirin or apixaban, dabigatran, or rivaroxaban. They have to be given for about 14 days in conjunction with TED stockings and vena flow pumps. So you should have your own guideline as to what sort of anticoagulant you're going to use. And then what sort of implant, you have to be familiar with it, whether it is a posterior stabilized or a cruciate retaining, fixed bearing, or a metal mobile bearing. It does not make a difference as long as you do it properly, align it properly, and balance it properly. In case of severe defects, anticipate the need for stems or augments and screws. In a nutshell, the success mantra for a total knee is most important is the patient selection. Choose your patient correctly and optimize the patient properly, giving a safe surgery in a safe theater environment. Be familiar with the processes and surgical technique. And ultimate goal is to achieve a well-balanced and aligned prosthesis. Balancing, I think, is the most important aspect for the success of a knee replacement, and do a proper cementation if you're doing a cemented TK, and give a stable fixation, and never come out of the operating theater leaving the knee in a little bit of flexion deformity, because it's only going to get worse post-operatively. So make sure that you achieve a full range of movement on the table, and patient who are left with a flexion deformity will never be happy and will not be able to walk properly. Having said that, getting it right first time is very apt in case of a total knee replacement. This applies to any surgery, but for a total knee, it is very, very apt, and because you may not get a second opportunity if you don't do the primary surgery properly. Thank you.
Thank you so much, Dr. Chandrasekhar. That was a wonderful talk on decision making. Now I request Dr. Jagan Mohan Reddy to start sharing your screen, and he is going to speak on prosthesis selection. Is there a guidelines? Over to you then, Dr. Jagan Mohan. Yeah.
Can you see my screen now?
Yeah.
Yes.
Make it full screen.
Yes, sir. Yes.
Yeah, good.
Good morning. Good morning. Thank you for giving this opportunity. Thanks to TCOS and TOSA. Thanks to Dr. Kasha and Dr. Somsekhar, sir. My name is Jagan. I'm working in SLG hospitals as a consultant orthopedic surgeon. And this big background, I graduated from Usmania Medical College, did post-graduation from Usmania. I did a brief service in Usmania General Hospital as an assistant professor. I spent 14 years in UK. I was a former consultant in Preston Hospital and Chorley. Did few fellowships on hip and knee in Crewe and Rotherham, and I was a lecturer in Birmingham Medical School. Did few research projects with Oxford and Warwick University. Today I'm presenting about the TKR process, which is the best one for the particular patient. And is there any guidelines to choose the implant or prosthesis? The standard primary TKR consisting of femur and tibia, you all know, this is a cemented cobalt chromium femoral component, maybe a CR or PS, and with a polyethylene liner. If you're replacing the patella, if patella resurfacing, and tibial component is modular, is most commonly used with a base plate plus liner. Most common material used is cobalt chromium or titanium tibial base plate. It can be a monoblock tibial. It may be all poly or metal back monoblock. The types of process depends upon the constraint, depends upon the material used. What is based on the constraints is unconstrained, semi-constrained, and fully constrained. In unconstrained, we have a cruciate retaining and posterior substituting and bicruciate retaining designs. And semi-constrained, we have non-hinged processes and hinged processes. And based on the material, we have metallurgy-wise stainless steel. They are older implants, around 40-50 years back. The knee implants are made with stainless steel, but nowadays in the modern implants, they are not using stainless steel. Most commonly used material is cobalt chromium. There are new implants, new materials are available, that is zirconium, silver coated, ceramic, gold materials. And depends upon the type of the polyethylene is cross-linked polyethylene, highly cross-linked polyethylene, highly cross-linked polyethylene with vitamin E supplementation. And based on the modularity of the tibial bearings, there are fixed bearings and mobile bearings. In a fixed bearings, again, it's a metal back on all poly. And based on the fixation of the implant, there's a cemented, uncemented, and hybrid. There are results shows both are equal, cemented or a little bit better than the uncemented. 95% of the knee replacements are all cemented. Only 5% are uncemented and hybrid knee replacements. And based on the geometry of the implants, it may be single radius curvature or dual or multi-radius curvature or medial pivot knee. Based on you are replacing the patella or not, whether to replace or not replace. If you are replacing, whether you are using a symmetrical button or asymmetrical button. If you're replacing, whether it's a metal back patella or non-metal back patella. The study shows there is no difference. It is a controversial subject whether to replace the patella or not to replace the patella. There are several papers that shows there is no difference in the patella resurfacing or not resurfacing. But some countries, some surgeons prefer to replace or not to prefer. Some specific indications are there, like malalignment of the patella tracking, malpatella tracking, or some surgeons do in a PS knee, they replace the patella. or anterior knee pain, persistent anterior knee pain, they use the replace the patella. And the other types are the gender specific knees and high flexed knees. The modularity in primary knee, the most of the modern implants are modular implants. Modular tibial component is now a standard one. It's a metal base plate with a modular polyethylene insert. Stems can be attached to the tibia and femur. Modularity advantage is greater intraoperative flexibility. Modular bearing can change for one polyethylene well-fixed implants. You can avoid the major revision. The disadvantage is backside wear. There is a micromotion between the base plate and the polyethylene. Even though there is a good locking mechanism, it allows some micromotion that will cause the backside wear and causes the osteolysis. And non-modular ones are monoblock designs. Tbl polyethylene bearing is pressed onto the metal base at the factory level. There is no backside wear with the monoblock designs, but there is no modularity. It's not that surgeon friendly. The most commonly used unconstrained knee replacement is either CR or PS. Cruciate retaining design is a minimally constrained, depends upon the intact PCL to provide the stability in flexion. The indications are arthritis with a minimal bone loss, minimal soft tissue laxity, and intact PCL. And the deformity should be minimal, like 10-degree varus deformity, less than 15 degrees of valgus deformity. And the PS ones are slightly more constrained when compared with the CR that requires sacrifice of the PCL. Femoral component contains the cam that engages the tibial polyethylene post during the flexion. What are the indications for PS design is absolute indications are previous patelectomy, inflammatory arthritis, and deficit or post-traumatic PCLs. But there are some relative indications like severe deformities, balancing is easy with the PS knees. This is the table comparison between the CR and the PS, the advantages and the disadvantages. In CR, the advantage is it retains the PCL proprioception, no post wear, no cam jump or dislocation. You are taking less bone resection, slightly increase the congruence, theoretically less wear, more closely resembles to the knee kinematics, which is a controversial subject. What are the disadvantages? Difficult to balance. The tight PCL may cause the accelerated polyethylene wear. In the post-op or later period, the PCL may rupture or non-function, may leads to flexion instability and subluxation. The PS advantage is it is a more reproducible results, slightly increase the constraint. The PS total knee arthroplasty often easier to balance than the CR knees. Kinematics are more consistent with the cam post designs. What are the disadvantages with the PS knee is the post wear, cam jump and dislocation. There is a slight elevation in the joint line, patellar clunk syndrome, patellar baha, and it requires additional bone to be removed from the distal femur. And especially small femurs, size 1, size 2, especially Asian females, if you take the large bone chunk for the box cut, there is a risk of condylar fractures. The other liner is a highly congruent liner, also called stabilized, anti-stabilized polyliner. The medial compartment concavity allows the lateral compartment to translate between the flexion and extension. It creates a medial pivot. The normally CR femoral component is used. The tibial insert is highly congruent bearing with a raised anterior lip. This anterior lip will resist the anterior translation. So what are the advantage with the highly congruent liner is easy to balance, bone conserving, operative versatility, don't have to switch to PS femur, and regulate the flexion kinematics. Highly congruent liner limits the sliding wear. So what are the disadvantages? Increase the polyethylene surface area and increase the risk of increased polyethylene wear debris and osteolysis, and the minimal rollback in highly congruent liners. The outcome shows equivalent outcomes with the highly congruent liner with the CR liners. And there the other implant is available is bicruciate retaining. Implant is similar to the unicondylar arthroplasty. It is an anatomical design, means you are recreating the patient joint line. The native collateral ligaments, ACL, PCL ligaments are being preserved. They will remain powerful drivers for knee kinematics. Controversial whether the cruciate preservation provides any proprioceptive advantage to the patients, but histological study shows mechanoreceptors found in the cruciate ligaments. but clinical studies failed to show the significant difference in the proprioception with the retaining implants, sacrificing implants. Bicruciate retaining TKR is more technically challenging because you have to preserve the soft tissue preservation. There is a strict selection criteria similar to the unicondylar knees and very little opportunity to adjust the deformities. If it is severely grossly deformed, you can't do the bicruciate retainings implants. And the other one is a mobile bearing designs. They are the minimal constraint process where the polyethylene can rotate on the tibial base plate. Rotating platform can be used with both CR designs and PS designs. The indications are very relative indications, young and active patients. The advantage is better articular conformity throughout the entire range of knee movements. Theoretically, less polyethylene wear, equivalent survivorship to the fixed bearing knees, but not superior. The disadvantage is a little bit technically challenging. You have to balance well, especially sagittal balance. If the flexion gap is loose, there is a risk of spin out. The paper shows that there is no significant difference between the mobile bearing and fixed bearing. And the other one is all polyethylene base plates. It's a monoblock. Indications, there is no clear indications, but it's a very less expensive, decrease the rate of osteolysis, no backside wear. Disadvantage is it's not that surgeon friendly, less modularity. If you use all poly, especially in weak osteoporotic bone, there is a risk of subsidence. The study shows equivalent functional outcome with a decreased cost. And the next one is a constrained total knee. It's rarely used in primary total knee replacement, but in complex primary total knee replacements like severe bone defects, severe grossly deformed knees, the primary TKRs, you can use the constrained options. There are two constrained options. One is a hinged option, another one is a non-hinged options. Non-hinged ones is high tibial post, and hinged options are with a tibial platform, rotating one and non-rotating one. And constrained non-hinged TKRs ones are high post one. It gives a coronal stability and rotational stability. What are the indications is residual flexion gap laxity and MCL attenuation, LCL attenuation and deficiency, MCL complete deficiency and Charcot orthopedy. Advantage is prosthesis allows the stability in the face of soft tissue or bony deficiency. Disadvantage is a more constrained one, the high rate of aseptic loosening, more polyethylene wear, damage to the polyethylene post, more femoral bone resection is necessary to accommodate the large bone box. The other one is a hinge TKR. The femoral and tibial components are linked with the connecting bars and bearings. There is a fixed extension stops. Most designs incorporated a tibial rotating platform. This reduces the torque stress to implant bone interface. The indications for hinge TKRs are global ligamentous insufficiency, hyperextension instability seen in polios and tumor resections, and resection for tumor, massive bone loss in setting of neuropathic joints. The advantage is prosthesis allow the stability in face of soft tissue and bony deficiency. Same disadvantage is a highly congruent one. So aseptic loosening as a result of increased constraint, a large amount of bone resection is required. The other one is a high flexion type of knee process. Generally, you achieve around 120 degrees of knee flexion with the traditional implants, but high flexion, it gives additional 10 to 15 degrees of knee flexion. Few papers suggest of there is a 10-degree increase in the flexion range, but some meta-analysis shows that there is no difference between the standard implants and the high flexion type of knee process. And the gender knee, around 30 years back, the TKR component, femoral component is symmetrical. There is no right and left. But later, the more biomechanics understanding of the knee, they designed right and left. And later, they found there is a gender difference between the male and female anatomy. The implant will overhang. There is an anterior flange thickness and trochlear groove angle, and mediolateral and anteroposterior aspect is different when compared with the male and female. And there is an overhanging of the implant in both the anteroposterior and mediolateral, which may lead to soft tissue irritation and affect the soft tissue balancing. Needs an intraoperative adjustment to compensate this overhang. Gender solution femoral components have been narrowed mediolaterally. That will help to address these issues. And the gender solution implants will reduce the anterior flange thickness of the implant and recessing the patellar sulcus, avoiding the overstuffing that may limit the postoperative range of motion. But the study shows there is no difference between the gender knees and the traditional knees. Early result shows there is equal or no superior to the gender knees. The other knees based on the material is, one is cobalt chromium, most commonly used implant. The other ones are gold knees. They are coated with nibonium. These are less wear property when compared with the cobalt chromium, harder implant, allergic preventive, and high wettability with synovial fluids, low friction, long-term chemical stability, avoids inflammation and endoprosthetic loosening, extreme adhesive strength. Another one is oxenium, most commonly used. Is a femoral component is made up of with oxenium or oxidized zirconium to undergo process that transfers the implant surface into hard ceramidized material. The surface hardness will increase and it is more scratch resistant. It lasts longer, reduce the implant wear, avoid risk of brittle fracture that can occur with the pure ceramic implants. 20% lighter than the cobalt chromium. It contains very less amount of nickel, can be used in metal allergic patients. There are few pure ceramic metal-free knee implants are available, but still under the trial. There are low risk of revisions for infection, safe in terms of metal ion release. Reaction to ceramic particles is unlikely. No risk of allergy, excellent biological behaviors, low wear of polyethylene against the ceramic, resistant to third body wear, highly scratch resistant. But the traditional, the result shows the equal when compared with the traditional cobalt chromium implants. Is there any guidelines to choose the implants? Is we have to take the INJAR guidelines or any joint registries. Most common standard ones is National Joint Registry by United Kingdom. These are the latest INJAR 16th edition publication shows the most of the knees are cemented, 95% are cemented, only 4% are uncemented, around less than 1% is hybrid. That is a femur is uncemented, tibia is cemented ones. There are reverse hybrid also available. The percentage of primary knee replacements by bearing wise unconstrained CR1s occupies 68%, and unconstrained PS1s are 24%. That's the second one, and the rest of them are mobile bearing and constrained condylar, and monoblock is 2%. So most commonly used poly is unconstrained CR. Second commonest used is PS1. The number of revisions when compared with the cemented and uncemented ones are both are equal, but uncemented there is a more risk of revisions. And when compared with the type of type of the insert, the least one is unconstrained fixed is the least revision rates. The most is constrained condylar, highest revision rate. So in summary, implant selection is one of the main factors controlled by the surgeon that can affect the outcome. You have to use a national and regional registry. Data can be useful for evidence-based decision making, but unfortunately in India, we don't have any registry. The bodies like TCOS or TOSA or Indian Orthopedic Association or big players like Dr. Gurwar Reddy sir can take a role to start Indian Joint Registry so that it gives an idea, it gives a guidelines to the upcoming surgeons, upcoming arthroplasty surgeons. Nowadays, it is very easy. We got an Aadhaar card, they can link it. You can form some guidelines recommended to the IOA to start the Indian Joint Registry to get a clear guidelines to get which implant to be used, what to be used, what not to be used. Registers typically publish an annual report containing the rich data on patients being treated and revision risk rates. It is recommended that surgeons use the register data in combination with peer-reviewed literature. Be open to revising your selections and choose an implant that you are familiar with it. Don't try new things at the beginning of the career. Cemented cruciate retaining or PS knees for the most of the straightforward knees. In the primary total knee replacement, straightforward knees, not much deformities. You can get away with the CR knees or PS knees. And modular knees are better. And good operative technique, well-balanced knee will give an excellent long-term results. Cobalt chromium implants are fine for the most of the knees. Don't go for any fancy implants, but only specific indications like metal allergy, you can use the zirconium or oxenium implants. Thank you.
Thank you so much, Dr. Jagan.
Thank you.
That was a wonderful talk on a difficult subject. So now I would like to request Dr. J.V. Srinivas to speak on bone cuts and ligament balancing, which is the most important part of a total knee replacement surgery. So Dr. J.V. Srinivas, is he there? Dr. J.V. Srinivas, sir, are you there? We are not able to hear you.
Shall we get on to Uday?
Shall we take the next speaker? Okay. Uday, next is Uday, right? Right.
Uday, are you ready?
You...
You can
Yeah,
share
I'm
the
ready,
screen.
sir.
Yeah, share the screen.
Yeah.
So, Dr. Uday's topic
Can you
is
see me, sir?
varus knee. Yeah.
Yeah, I'm starting. Can you see me?
Yeah,
Yes.
good. Yeah.
Yeah, thank you. Thank you, Dr. Srinivas, Dr. Somashekar sir, and from the TOSA, Dr. Sudhir and Vijay Bhaskar. Thanks for giving me the opportunity. We missed Dr. J.V. Srinivas. I don't know if I was chatting there. My topic is TKR in varus knee. I made it very simple to understand for the basics of knee replacement, because this is the most common procedure with 80 to 90% of patients are with varus knee. The core principles of TKR are the same: to achieve the alignment, to achieve balance, flexion extension gap balance, and achieve good range of motion. So the pre-operative workup, what the previous speakers have said, it's a valid point where it should start with the clinical examination along with radiological support, because the patient walks with good varus stress that indicates that some amount of medial laxity. So I always include certain X-rays. One is the weight-bearing X-rays, compulsory standing X-rays, lateral views X-rays, and full ankle, hip, knee, and ankle scanograms. And if you have any suspicion, like for stability issues, you can take a valgus and varus views.
Sir,
Valgus view. Hello. Yeah. Hello. Valgus views.
Uday,
Uday, go ahead.
on,
We can hear you.
Yeah, go ahead. Yeah. Someone interrupted. Yeah.
No.
So it has the good impact of knowing a valgus view for stretching of any medial collateral ligament. So what is the pathoanatomy of the varus knee? It's very simple. The most common X-rays now we see the days is this varus knee. The bone defect starts usually on the medial side, where there is an MCL contracture plus medial OA overgrowth. There will be impingement of the ligament and relative shortening of the MCL, and fixed varus deformity starts. So before beginning the skin incision, just I have to mention that the most common approaches are midline, medial parapatellar approach. The other approaches are subvastus and midvastus. But I use the same approach for all the gross varus knees or even the valgus knees that can be addressed with this standard medial parapatellar approach. Before starting the incision, there are you have to know the importance of blood supply around the knee. The most important branch is saphenous branch of descending and supreme genicular vessels, that is on the medial side. So there is an abundant medial supply of the vessels which forms anastomosis around the knee joint. That's why in any revision case or any previous incision, we ask we will train our surgeons to take the incision on the more lateralmost incision to avoid any medial incisions, to avoid any scarring, because the blood supply it has from proximal to distal. So you should always take care of the middle blood supply. Well, starting the incision, always wear a tunique with a nice flexion of the knee. Just a video. It's rotating.
So Uday, video will not run on a Zoom. We have to open a different video, I think, window, I think.
Yeah.
You,
Yeah, it's opening, but sorry.
no, you can play from the laptop itself. That part, if it is important.
Yeah.
Directly.
Yeah. It's not enlarging.
Go to the folder.
Folder.
Yeah.
Yeah,
I'm going to the folder. Yeah. Yeah, sorry for that. Can you see now?
Yeah.
Yeah, see, actually the midline approach is the most common, where from the superior part of the patella, 5 centimeters above, some skins are very, very friable and some bones are very prominent. You should be very careful on dealing with the flaps. Mostly on the lateral flap, you should never elevate a lateral flap because of the sparse blood supply. You can elevate minimum amount of medial flap if you required so. The most important thing is to cauterize, because I don't use tunic, I don't use any other drain or everything. I cauterize, and I use 1 gram tranexamic acid so that the bleeding is well controlled. So the most important thing is to cauterize all the vessels and start for the arthrotomy. Yeah, in the arthrotomy medial parapetalar approach, this is where they start with the knife, nicely cutting, and end with near the upper part of the tibal tubercle. So we should leave a cuff of a soft tissue between the tendinous and the muscle junction, so that you can reattach later without any skin healing problems. So that's yeah. I'm stuck. Oh, okay. Yeah. Next, coming to the varus deformity. This is a very most important. In the varus deformity, you have to know the structures which are giving the tight contractures. There are most important ligament are deep medial collateral and superficial medial collateral ligaments on the middle side, and posterior oblique ligaments. Whenever you have deformity, if you want to have flexion gap or extension gap maintenance, you have to see that the anterior structures, the anterior middle part of the knee, that is a deep medial collateral, that should be released, and check is there any opening on the flexion gap. Usually it opens up. When you go more varus deformity, the posterior medial release should be done. Sometimes we find it's so tight, it's a difficulty of releasing the ligaments. Sometimes you may suddenly swap the superficial middle collateral. That is a very, very important. Never ever release the superficial middle collateral. Otherwise, you land in trouble. Opening of the middle joint, again, you have to go for constrained one. In the severe varus knee, where there is a severe bone overhang, you can remove this or osteotome, so that you have a working gap, and there will be less pressure on the middle collateral ligament. And sometimes your release should be very, very sequential, and see that it never goes beyond superficial middle collateral. I'll open in another window. Sorry for that. You can use a cautery or knife. But first, I'm releasing at the deep medial collateral. It's between the capsule. it is capsule at the junction of the capsulus meniscus junction there. You have to release very, very slow. Initially, I used to release up to the posterior medial corner, but now I restrained while after cutting a little bit of bone, then I'll again come back and check release. If you have a sudden release, then you should always check with the one finger that superficial medial collateral is intact. Most of the varus deformity can be corrected with the posterior medial release and posterior medial tibial osteotomy and subperiosteal elevation of the MCL that can correct up to 20 degrees of varus. The algorithm, what is best for the medial release is in varus knee. Actually, in the deep MCL release, if there is a tight flexion, the anterior medial structures, that is deep medial collateral and some of the capsules that should be released from the anterior part to have opening of the flexion gap. And if it is more tight, do a medial reduction osteotomy. If it is an extension, the posterior medial structures in the capsule or the semi-membrane structures that should be released, if required, do a posterior medial reduction osteotomy. The removal of the osteophytes are very, very important to remove the tenting of the MCL. Next is coming the balancing the cuts of the bone, where it helps in balancing of the ligaments. I use gap balancing, sometimes very rare. I use measured resection. In gap balancing, whatever the soft tissue release initially you should do, then you go for cuts. Again, if you want, you can come back and release little bit. So I'm familiar with this. The main aim, as mentioned in the previous talks, the axis should be in the perpendicular to the tibial axis. So and in the femur, it should be in the mechanical axis, so that to have a alignment of the hip, knee, and ankle axis. Really sorry for that. Sorry. In cutting the tibia, there are three important points. One is your mechanical axis alignment. You can access to the bone of the tibia and have coronal alignment. You can adjust according to the bone, and you can adjust the height where amount of the bone should be removed. And third one is your sagittal. The amount of slope, you can adjust that one. According to that, you can adjust in the middle of the talus. You can align and see that you cut a very little amount of the bone, checking from the stylus of the lateral plateau, so that you'll have less amount of bone. Normally, it is around 9 to 11 mm. Your saw should be perpendicular, and see that you protect the patellar tendon there, and entire thing should be elevated. Coming to the distal femoral cut, the ideally the anterior to the incision of the PCL, you can directly enter into the canal. It's an intermedullary rod, and if you enter too posterior, may lead to the femoral component inflection or inequate femoral cuts. The most important criteria for varus knee or any other thing is to have a balanced flexion and extension gaps. If you cut the proximal tibia, you have both flexion and extension gaps. It'll helpful in distal tibia, especially in the extension gap only if you cut it. And in the posterior femur, you have the flexion gap only. That is, I'm coming to that. I use a combination of our approach. Aim is equal balance flexion and extension gap, and the extension gap first, where coronal alignment we have to maintain. That is the proximal tibia cut, distal femur, and ligamentous balancing. The last comes the flexion gap, where in the time of rotation, I'll explain you. When you cut it, what happens is sometimes you see this on table. That is a trapezoidal extension gap. That is on the middle side is a little bit tight. On the extension, it tight means that is the posterior middle structures are more tight. You have to check for any osteophytes and posterior middle release and posterior femoral condyles and sometimes capsule. And put the spacer, check for the ligaments after the release. Yeah, very rarely you can downsize the tibia or do a reduction osteotomy. In the femoral component rotation, this is very important. Otherwise, what happens is your femoral tilt can be a problem, and patellofemoral problems it may arise. Subluxation or dislocation of the patella can arise if you have an internal rotation of the component. It can also arise with excessive medial release or proximal tibial cut varus in a varus position. Always have three notions. One is your femoral component rotation. One is transepicondylar axis from one condyle, epicondyle to epicondyle. That is very commonly easily palpable. In navigation, what we use is also the same one, and is easily helpful. In very rare instances, where in cons where is there any malformation of the condyles, you have to use for a white set line. It starts from the trochlear sulcus to the midpoint of the intercondylar area. In any hypoplastic in the region, it is not useful. The third one is the posterior condylar axis. This is very important because it makes an angle of up to -1 to 9 degrees with the transepicondylar axis. Sometimes, if you any bone loss on the posterior condyle, this may not be useful. So you should be careful in the rotation of the component, because your rotation of the component will determine the longevity of the femoral, longevity of the femoral implant. You should always see your femoral rotation is always with the transepicondylar axis. So in this, I use Smith & Nephew Genesis 2 with the stylus, there in the most anterior prominent part of the bone, and see that there is no notching. And you should be always hold. The surgeon should always hold yourself to prevent any interlodation. If your assistant holds, if it deviates, sometimes it may goes for excessive interlodation. Sometimes it goes in interlodation. You should hold it and directly place it. Then while placing the box cut, you recheck it and thumb nicely to the bone so that it doesn't have any gaps. Second thing is you cut slowly, very, very slowly. This is the anterior cut, so that you don't have any notching. Check properly. In the posterior one, you should always keep an osteotome. See that you don't go more deep. Especially on the middle side, the medial collateral is very, very close in this area during the posterior chamfer cut. So you should be very careful in using the saw in that area. You remove all the bone that is available and nicely remove and check for the balancing. Yeah. Sorry for that. Only one slide. After having a good rotation, you have to check for final checking so that you have a good flexion extension gap and as well as ligament balancing. At the end of the day, the take-home message is to achieve alignment, achieve a balance, good range of motion, and algorithmic approach to middle release. There's always the anterior part and posterior part. Anterior part has important influence on the flexion gap, and posterior part of the structures, that's the posterior medial capsule and the superficial medial collateral and the semimembranous and other posterior capsule release have important on extension gap. Gap balancing or measure resection. I've tried both, but both works well and especially helpful for non-deformed knees. Thanks for the opportunity and sorry for the inconvenience.
Thank you, Dr. Uday. Now we go ahead with the previous talk by Dr. J.V. Srinivas about the most important topic, that is bone cuts and ligament balancing.
Thank you, Dr. Srinivas. Just give me a minute. Let me share the screen. Is my screen audible now? Am I visible?
No, not yet, sir.
Just give me a second. Okay, the file is not Microsoft PowerPoint. Open it on the.
You can share the screen first and then select PowerPoint, sir. That is easy.
Yeah, I'm just open. Is it?
So meanwhile, let me ask a question to Chandrasekhar. Chandrasekhar, are you online?
And I'll unmute.
Yeah. Just a question to you. Meanwhile, till it is open. Yeah.
Open now?
So it is already on. We'll discuss it during.
Man. First of all, I thank Dr. Srinivas and Telangana Orthopedic Association for inviting me. Sorry for this technical glitch. I'm little computer ignorant, and there was a little internet connectivity issues. First of all, my talk was on bone cuts and ligament balancing. Dr. Uday has already given an excellent presentation on varus knees, which I'll cover a little bit because ligament balancing cannot be completed without touching the varus knees. Okay, so primary total knee arthroplasty, whether we use a CR design or CS design, the clinical results are influenced by surgical technique. As you all accept and agree with me, surgical technique is absolutely essential and very important to give a good result, whether you use a CR, CS, or any company design. Adherence to the basic principles of surgical technique ensures a successful outcome. So the goal of primary total knee replacement is to re-establish the normal mechanical axis with a stable prosthesis and well fixation. To achieve it, you need to have two important criteria. One is bone resection, and second is a soft tissue balancing. Dr. Uday has already mentioned and shown a video about medial parapatellar arthrotomy, and most of the surgeons do this. Some of them do a sub-vastus approach, a mid-vastus approach, but most commonly use a medial parapatellar approach. Once we do it, once the knee is exposed like this, the three main bone cuts, which is very essential for a successful total knee replacement, is the proximal tibial cut, Distilled Femoral Cut, and the posterior cut. Usually, the amount of bone what we resect corresponds to the thickness of the implant what we use there. So these three important cuts are very essential: the tibial cut, proximal tibial cut, distal femoral cut, and the posterior cut. The remaining cuts may not be that essential, but these three cuts dictate the results because they influence your extension and flexion glaps. Moment you see this kind of X-ray, I'm sure 90% of our surgeries are X-rays like this. May not be a gross deformities, but most of our surgeons, and you, whether it's Hyderabad, Bangalore, anywhere, most commonly seen is varus knees like this. And moment you see the X-ray, and in your mind, these lines should start coming up. You should assess your mechanical axis on the tibial anatomical axis and what the tibial cut, what you're going to do, perpendicular to the tibial axis, and the femoral axis and the valgus angle at which you're going to cut, because we have to be perpendicular to the mechanical axis, not the anatomical axis of the femur. So tibial cut, as you all know, we use different system. Some measure from the medial, which is less affected side, or some use the lateral side. If it's a medial side, it should be 0 to 2 millimeter thickness, or it's the lateral side. In a varus knee, I'm telling, in the lateral side, 8 to 10 millimeters, based on the system what you use. So tibial cut is absolutely essential. It is the most vital part of your total knee replacement. It dictates the extension space, flexion space, and the alignment of the knee. So tibial cut should be resected, as I said, 90 degrees to the anatomical axis, 2 to 3 millimeters from the less affected, 8 to 10 millimeters from the lateral side. The tibial slope is dictated by the prosthetic design. If you're using a mobile bearing design, certain companies advocate 0 degree posterior slope. In a fixed bearing, some advocate 3 degrees, some advocate 5 degrees, some use a natural posterior slope based on the company design. You have to decide which implant you're using. According to that, you decide about the slope. As I said, tibial resection influences both flexion and extension gaps. Remember, the more tibia you resect, the bigger tibial insert you land up with. Definitely, you land up with bigger tibial insert. Second most important cut, what we do is the distal femoral cut, which is second most. The femoral component, normally you can take a valgus between 3 degrees to 10 degree valgus to the anatomical femoral axis. So 0 to 10 degree flexion. Okay, 0 to 10 degree flexion. But as a standard procedure, most of the varus knees, we are using, am I audible?
You're audible. You're audible. It's clear also.
Am I audible?
Yes, yes. Yes, Dr. Srinivas, please go on. We can hear you. We can hear you, but I'm not sure whether you are able to hear us.
Give me a second, please.
We can hear you.
I'm audible now?
Yes, yes. You're audible.
Yeah. Sorry. Okay.
Okay.
Distal femoral resection. Give me a second. Okay. 3 to 10 degrees valgus angulation to the femoral anatomical axis. Normally, we use 5 degrees for a varus knee, but some people for a valgus knee usually take 3 to 4 degrees. Some may take more based on the femoral anatomy, the bow in the femur, anterior bow, and the varus angulation. And flexion, again, most of the companies give 0 to 3 degrees. But again, if you're a navigator or using a robotics, you can use higher degrees based on the anterior femoral bow. Distal femur resection selectively influences only the extension space. Usually the distal femur resection, as I said,
sorry, I can't search by topic, but I can search by title, actors or directors, and categories like thrillers or comedies.
Okay. So usually the distal femur is resected 9 to 10 millimeters of an unaffected normal side, which dictates the thickness of the implant what we use. So resection of distal femur, over resection, remember, if you resect more, the extension gap will be large than the flexion gap, then you will end up having a recurvatum, which is more disastrous. Always you can cut less and then go ahead. If you cut more, you cannot come back unless you have a backup of a revision implants or a distal femoral augments. Under resection creates a flexion contracture. Still, that is okay. You can go ahead and recut the distal femur. But if you cut excessively in the first go, then you are in a difficult situation. Then the third thing is sizing. We do have two different kinds of methods of sizing the distal femur. We all use the anteroposterior diameter, not the mediolateral diameter. The two most commonly used is posterior and the anterior referencing. That is the two different types. Anterior referencing system is the one where your anterior cut remains same. Whether you increase or decrease the sizes, the amount of bone removed would be from the posterior side. That is called the anterior referencing system. Posterior referencing system would be the posterior cut remains same. The amount of bone removed posteriorly remains same. So yeah, and the anterior part would be changing. A system like this, you should be very, very careful in the posterior referencing. In case if you're undersizing, if the size comes in between two sizes, you try to undersize, then you land up notching the anterior femoral cortex if you're using a posterior referencing system. In an anterior referencing system, if you're undersizing, that means you're taking excessive bone from your distal posterior femur, you'll end up having a larger flexion space. So Whenever you're doing a sizing of the femur, you always make sure you need to recreate or replace or maintain the posterior condylar offset. If you completely undersize your femoral femur size and reduce the femoral condylar offset, you will end up having a reduced flexion and impingement of your polyethylene posteriorly. Again, once you have sized the femur, anterior posterior chamfer cuts. These are very important, may not be as critical as distal and distal femur and the tibial cut, but anterior cut is again little important. So posterior femur resection, as I said, selectively influences only the flexion space. If the flexion space is larger than the extension space, then the posterior flexion instability will start. So it is recommended that the amount of bone resected should be replaced by the implant unless it's a special situation or a complex situation. The anterior femoral influences the flexion space and the patellofemoral joint. You remember, if the resection from the amount of bone resected from the anterior femur depends upon the sizing of the femoral component what we use and the position of the anteroposterior cutting jig. In case your cutting block is in flexion, extension, if it is in flexion, you will not notch it. But if your cutting block is in extension, then you will end up having notching of the femoral cortex. So these are the factors which affect the anterior femoral resection. Under resection of the anterior femur inappropriately increases your femoral component thickness, and it will be having excessive implants in the anterior part, that is patellar component and the femoral component, leading to anterior knee pain. It overstuffs the patellofemoral joint. If you undercut the anterior femur, it overstuffs their possibility of limited range of movements and patellofemoral dysfunction. Over resection, as I said, you may land up having notching of distal femur. Notching up to 1 or 2 millimeters still accepted. Anything beyond 3 millimeters of notching will increase the risk of periprosthetic fracture post-operatively. Femoral component rotation, Dr. Uday has clearly mentioned. Normally, we do 3-degree external rotation. TKR will never accept femoral internal rotation. You can have 1 or 2, 3 degrees of extra external rotation, but internal rotation is never accepted. We normally use epicondylar axis, which is more reliable, more easily you can calculate the epicondyles and take that as a reference for femoral rotation. But some people can use Whiteside line or posterior condylar axis, very rarely used, because most of the time if you're in a valgus knee or in a severe deformed knee, the posterior condylar axis may not be right. If you're a navigator, then again, or are using a robotics, it's a different story. I'm talking about a conventional total knee replacement. Following a soft tissue balancing, setting a femoral rotation along the epicondylar axis creates a balanced rectangular space. So this rotation is absolutely essential. As Uday said, we need to have a rectangular space, whether it's an extension or inflection, it has to be rectangular. You cannot accept a trapezoidal space. So as I said, matching of femoral component to anteroposterior dimension is recommended. None of our system takes the mediolateral dimensions. Anteroposterior sizes is always recommended, and whatever system we use, when we land up in between sizes, it's preferably to go for downsizing. When you go for upsizing, you will have a larger femur and patellofemoral mechanism will be a problem. Mediolateral horang may be a problem. Always we go for undersizing and distribute your bone cuts between anterior and posterior equally. Very important. Ideal system should allow that additional bone resection to be divided between the anterior and posterior condylar axis, as I said. And slight flexion in the distal femoral resection avoids anterior notching. That is, if you are having a system which gives you a 3-degree flexion, if you are in a 4-degree flexion, it always gives you an idea, always saves your anterior cortex from notching. But in case, because you're using an old blade or a bent blade, your flexion reduces to extension, then you will end up having a notching of the anterior cortex. So once you know all these points, before you cut, again you use an angel wing, put it on the anterior surface, check whether you are going to notch or not. In case if you're notching, either you upsize your cutting block or you increase the flexion, a couple of degrees of flexion on the cutting block, then you avoid the anterior cortex. Once you have done the anterior anteroposterior cut, distal cut and the tibial cut, you check for your spaces. An ideal knee replacement would be situation where your flexion space and extension space are rectangular and equal to each other. You cannot have irregular one. Spacing is very, very important. The using of spacer blocks has helped us, and rather than using a crude manual method, spacer blocks are very, very ideal. And that's a flexion space and extension space. Always we have to do when you're doing a conventional knee replacement with a rod on this, checking for your alignment when you're correcting your deformity. So gaps are influenced, as I said, flexion and extension. The tibial cut will influence both flexion and extension space, whereas your distal femur cuts only affects your extension space. So an ideal TKR would be just right flexion space, just right extension space. We have to get it first time right. You cannot expect a revision within a short period. As a previous speaker said, the first time is the best time. You need to get everything right on the first time. So this slide is very important to adjust your spaces. If your extension and flexion space is tight, then remove tibia because it helps both the flexion and both affects flexion and extension. Extension is tight, whereas flexion is normal. Then remove the distal femur because you have under removed the distal femur. That's the reason extension is tight. Extension is normal, flexion is tight. Where flexion is tight, either you downsize the femur using an anterior referencing jig. Remember, not a posterior referencing jig, or increasing the posterior slope of femur. Extension is normal, flexion is loose. This is a difficult situation. You need to use a larger femur with a posterior augments. I'm sure when you're doing a primary total knee replacement, you don't have augments as a backup unless you have anticipated this problem and kept in your operation table. Extension is loose, flexion is normal. That means you have over resected your distal femur. You have done a gross mistake. Then you should have a backup for distal augmentation of the femur. Extension and flexion is loose. That means tibia cut is more. You need to use a larger insert. I'm sure all the young surgeons have to display this chart, the combination and permutation which I spoke now. Put it on your operation table whenever you're doing a surgery. If you have any trouble, you can look at it. At the end, once you know your cuts are good, your spaces are good, rectangular, then finally finishing your preparation for the tibia and femur, and whether using a fixed bearing, a mobile bearing, does not matter, and final implantation and femur and the tibia, and you need to have a good total knee replacement X-ray like this. So varus deformity. Now I come to the soft tissue balancing. Most common is varus deformity. Dr. Uday has completely in detail he has spoken to us, and then I'll just touch about the soft tissue management only. Typically, when varus knee, contractures of the medial, that is medial collateral ligament, posteromedial capsule, pes ancenaris, and semimembranous muscle are the soft tissues which are very tight. Correspondingly, on the lateral side, there will be elongation of the lateral collateral ligament in a late event or a severely varus knee. In a valgus knee, it's extremely opposite. On the lateral structures at right and medial side may or may not be loose. So progressive release on the medial structures until you reach the length of the lateral structures is very, very important and the basis of the correction of deformity. But if you do, as Dr. Uday said, if you do excessive release, you will land up in trouble and having a medial laxity. So you should have a sequential release. Usually what we do is we release the medial collateral ligament on the medial side, release the capsule entire medial side, and then posteromedial corner. Most of the time, releasing these two structures, your deformity is corrected, and removing of your excessive bone and osteophyte on the medial side. 99% of your cases, which I showed one case like that, 99% of case you're able to correct your deformity. Very, very rare situation, you have to think of releasing or subperiosteal release of superficial medial collateral ligament. When you're doing this, make sure you are having a constraint implant as a backup. If you don't have it, then you're in a trouble. So medial soft tissue release, normally in a primary knee like this, we usually go up to mid-coronal plane only, release the deep MCL, capsule there, and correct your deformity, and most of your deformity is corrected. So begin the knee in extension, the soft tissue, begin the knee, releasing the extension, dissect subperiosteally to the proximal anteromedial tibia, pass the elevator deep into the superficial, protect your superficial MCL and then release the deep MCL and the capsule, take off the osteophyte, most of the deformity in varus knee is corrected. Very rarely we require an extensive release like this, where you pass your osteotome or COBS to release the superficial MCL up to 6 inches you can release, but it is in the very rare situation. In this situation, as I said, you need to have a revision implant as a backup. You cannot go and do with a primary implant. And you can go right up to the pes ancillaris. The moment you release, the knee joint will open completely on the medial side. Then unless you are having a good backup, you should not try to do this. This is how it is done, and you should be very careful when you do this. So how do you really assess your release is adequate? Many people put the knee in extension and start putting a valgus pressure to assess your release. But this is too crude, may not be very accurate. You can use a lamina spreader to assess your flexion and extension space. That is really good. Or you can use the most reliable is your blocks, which is available in our instrumentation. Spacer blocks are very, very good to assess your flexion and extension gap without damaging your ligaments. A varus knee like this, moment it comes here, you can see here, I'm sure 99% of our cases are like this, and all the surgeons operate like this. Here, if you see the medial osteophytes are there, and then the medial collateral ligament is contracted, we can see that the lateral structures is a little elevated. When I do a knee replacement like this, I'm very, very happy. The spaces are good. I've not done any releases, only a medial mild soft tissue release I've done, but the spaces are very good, range of movement is good. Most of the time when I have any suspicion like this, because how come I had a very tight knee on the tight structures on the medial side, lax on the lateral side, I'm very comfortable on the after implantation to check. This is I've shown a picture only. After implantation, I'm so comfortable. I normally take an image before I implant. I take an image on the operation table. Then we realize we have done a varus cut. That's the reason you've got a very good space in extension. That is, the medial tight structures is compensated by the varus cut. Then once you adjust your cut to a neutral cut, which is perpendicular to the mechanical axis, then your tight medial collateral ligament comes into play. And see, that's how you can see. If you see if you have not released your medial structure in varus knee and it is tight, when we do subluxation, your lateral part of your knee only comes anteriorly, whereas the medial part is hinging. That is, medial pivoting is happening. That means the medial patient has a medial tight MCL. Post-operatively, they have a lot of pain on the inner side, and they would be having a lot of pain and discomfort when they have flexion. Hope you are able to see the videos.
We are able to see the pictures, not videos.
Video?
No.
Now?
Even now. We can see the pictures, but no videos.
Okay. Sorry. Okay. Let me just show you. Give me 1 second.
Yeah, sure.
Now?
No.
Okay, so forget that. Okay, that's a medial. What I really wanted to show is if you have not done a soft tissue release in tight medial MCL, you will have a medial pivoting. The medial side is very, very tight, and lateral side is lax. When you do an anteroposterior movement, you would expect medial pivoting and the tibia going for internal rotation. So that is an indication that medial structure is tight. And then what I do is I use a 16 or 18 gauge needle, do a sequential release or multiple pinning of the MCL till you have an equal anterior posterior translation of the tibia. You cannot have a tight knee inflection. Then the patient would be having a lot of pain when sitting up on the chair, getting up from a chair. So you need to do a multiple pie crusting or multiple pith holes on the MCL, giving adequate relaxation of the MCL, and then good anterior posterior translation of the tibia. You cannot have a tight knee in flexion. So in valgus deformity, as the varus knee, the structure's most problem is on the lateral side. So valgus deformity secondary to the bone loss. Usually type 1 is secondary to the bone loss, but medial tissues are intact. Remember, medial tissues are intact. Lateral structures are tight, that is iliotibial band, posterolateral capsule, lateral collateral ligaments, popliteus tendon, biceps femoris, lateral head of gaster. These are all structures which may be tight and severe, but in a in a primary type 1 valgus knee like this, iliotibial band and the lateral posterolateral corner is the tight structures. In type 2, you have a valgus deformity secondary to bone loss on the lateral side. At the same time, medial tissues are lax. So in these patients, normally, most of the surgeons, when we started, this is a classical example of type 2 where the medial structures are lax. So the sequential release would be posterolateral capsule, iliotibial band, and the lateral collateral ligament. So the deformity correction would be in this order: the arcuate ligament or the posterolateral capsule complex release, then pike crusting of or multiple puncture hole on the IT band, release of the IT band from the geotic tubercle in case if it is a severe valgus knee or a tight knee. Very, very rarely we should be ready for a lateral condyle release or osteotomy. If you are doing a medial approach, once you have done you have to do a minimum soft tissue release on the medial side up to the mid coronal plane, because we cannot release excessively on the medial side. Posterolateral corner or the arcuate complex you release, extend the knee with a trial implant, and then you feel for the tight iliotibial band and do a multiple pike crusting pinholes, or using a 11 blade you can do it. Then the knee comes back to a balanced position. Other option is, what I do is regularly a lateral approach for a valgus knee like this. My incision would be same as medial parapatellar, the initial incision. Only the distal part I've turned it to the lateral. And this is a lateral parapatellar arthrotomy for a valgus knee. The incision itself is a lateral release for the patella, and the soft tissue release in the tibia is a correction, soft tissue release for the correction of deformity. So again, once you have released the iliotibial band and geotic tubercle, you go release your capsule complex right up to posterolateral corner, then the deformity correction is done. Once you have released that, flex the knee. I use the jig of the opposite side, use the medial side which is little affected for the measurement of the tibial cut. Go ahead and finish your tibial cut. That's a tibial cut we are measuring from the medial side. Then go ahead and do a distal cut. Again, make sure your rotations, because lateral condyle valgus knee, there will be a dysplasia of the medial side and a hyperplasia on the lateral side. So be very careful. You should not put your femoral component in internal rotation. Once you have done an anterior cut, make sure a grand piano sign, that's the indication that a good external rotation of your femoral component is there. Once it is done, flexion space like this. And once it is done, flexion space, you check and go for extension space. Once you are done, you go ahead with your implantation. Here the patella is everted medially, and that's an implantation, and that's your preparation of bone, and that's your implantation. And once you put your extension mechanism back in place, in a valgus knee, if you have done a lateral parapatellar arthrotomy, you cannot close the complete arthrotomy. Remember, only the lower 1/3 and the upper 1/3 you can close. Supralateral part of the patella you cannot close. It acts like a lateral release for the patella tracking. We only close the synovium in this layer, and then go ahead and close the skin is the next layer. And this is the alignment you get if you're doing a lateral parapatellar approach. Next deformity is flexion deformity. Here your flexion space is normal and the extension is tight. Remember. So it can happen in usually rheumatoid and the osteoarthritis. In rheumatoid, usually functional because of the pain patient keeping the knee in flexion. Contracture of the posterior capsule and collateral ligaments happen, and always associated with severe osteoporosis. Remember, when you're correcting a flexion deformity in rheumatoid arthritis, remember to have an intramedullary stem extension or rods. And correction is usually easy, and never try to correct completely on table for osteoarthritis. Do release of soft tissue and expect correction by post-operative physiotherapy. In osteoarthritis, deformity may be less, but you need to do complete correction of the deformity, and usually you have a large osteophyte posteriorly, capsule is lax, and it's very difficult to correct, and complete correction have to be achieved in the operation table. So the steps for correction of flexion deformity would be tibial cut. Once I have done a tibial cut, then we go for a distal femoral cut. Check for your extension space. If you're not able to get in the flexion deformity, not able to get a full extension, maybe 2 or 4 millimeters of extra tibial cut you need to take, you get for to get your full flexion, full extension. But you cannot do a distal femur cut, additional distal femur cut, because you're pushing a joint line high, and then you'll have a patellofemoral problem. So you need to keep your distal femur cut same, increase your tibial cut, get a good extension space. Then very important, very important in flexion deformity, you need to use an anterior referencing jig only, not a posterior referencing jig. If you're using a severe deformity, using an anterior referencing jig, you size the femur, and normally I upsize the femur. In case if your size is with 2, you take a 2.5 or a 3 based on the system what you use, because we need to keep extra bone posteriorly, because once you cut your tibia to get your extension place, if you use a normal femoral size, you'll end up in loose flexion space. That's the reason anterior referencing, upsize your femur, automatically your flexion space and extension space automatically gets adjusted. So once you know that, then you can go ahead with your anterior posterior cuts, chamfering cut, check your flexion space. And then in osteoarthritis, still if you have not got complete correction, you release the soft tissue, posterior capsule can be released. Any osteophytes are there posteriorly, release the osteophytes. Then check for your correction of deformity. If you have corrected, stop at this point. If you have not corrected, especially osteoarthritic patients, if you are not able to get correction, in spite of tibial cut, in spite of posterior soft tissue release, osteophyte release, then you do an additional 2 millimeter distal femur cut. This is the last thing we should do. It is not the first step in correction of flexion deformity. People directly take 2 millimeter distal femoral cut. That means you're moving a joint line up, and you may land up in mid flexion instability. Then check for spaces. Then if you're comfortable, go ahead preparation and then implantation. The last component is genu recurvatum. It's a very challenging situation. You have to plan pre-operatively. So in this situation, flexion is normal, extension space is loose. Remember, extension space is loose. You go with the standard first thing tibial cut, then distal femur cut. Moment you put the jig, you have to remember, you don't cut 9 millimeter, you cut 7 or 5 millimeter. Cut less bone. Check for your extension space. If in a PFC system like this or any system, you put a pin on a 0, you move it to -2, that means you're reducing the cut to 7 millimeter, or sometimes you can go up to 4 millimeter less. That is, instead of cutting 9, you cut 5. Check for the extension space. If your recurvatum is corrected, then you proceed the surgery like a normal surgery. In case your recurvatum is not, that is, you still have tight, you can go 1 or 2 millimeter above, but never cut normal 9 millimeter. If you cut 9 millimeter in recurvatum, your surgery is failed on the first step itself. Then check for your flexion space. Then final implantation. Always weight bearing x-rays are very essential before doing a knee surgery, because our women who are having severe arthritis are short, obese because of they wear a sari, and because of their thick fat pad, most of us do not recognize this recurvatum. This is a lady with a full weight bearing lateral view. You can observe your recurvatum. If you don't pick this up, you will land up on a problem on the operation table. That's a post-operative X-ray with a good extension space. So to summarize, the basic principles of total knee arthroplasty is to restoration of mechanical axis, restoration of joint line, balance of soft tissues, equalizing the flexion and extension gaps by your cuts and soft tissue management, restoration of patellofemoral and patellofemoral alignment and mechanics gives the best result for the patient. Thank you very much.
Thank you so much, Dr. J.V. Srinivas. That was a wonderful talk on bone cuts and ligament balancing. And next, I would like to request Dr. Sai Lakshman to talk on TKA in valgus knee. So can you stop sharing, Dr. J.V.
Yeah,
Srinivas?
I'm not sharing. Give me a second. Yeah.
Over to you, Dr. Lakshman.
Thank you, Asha. Yeah. Share. Can you guys see my talk?
Yeah. Just.
Yeah. Now I'm going to talk about achieving balance in valgus. I'll pick up where JV has left us. The 5 golden rules of a knee joint replacement. But before that, I thank Dr. Kasha, Dr. Somsekhar Reddy, Dr. Guruvar Reddy sir, my teacher. Sudhir. I don't think he's here. I thank Sudhir and all the participants. The 5 golden rules: you have to align the knee by achieving a ligament balance, obtaining full range of motion by equalizing flexion and extension gaps, and of course, finally centralizing the patella. These are the things that you need to achieve as a rule to have a successful arthroplasty. Doesn't matter whether it's a valgus or a varus, these are to be achieved. Now, my topic is dealing with the valgus. With the introduction already JV has given us, I think it's much easier for me to go about with my talk. Normally, you would expect wear and tear and joint space reduction on the medial side, but when you see that there is medial joint space is normal or actually sometimes increased, and then reduction in the lateral joint space, then you know that you are dealing with a different kind of situation. Why does some people have this? It's not that you see these kind of things regularly, but maybe less than 10% or 5% of your practice also will involve valgus knees. It can be because of a bony hypoplasia, a deficient lateral femoral condyle or a tibial condyle or a tibial plateau, or most of the times it's a soft tissue imbalance. Tighter structures on the medial side may or may not be associated with the attenuated MCL. Why is it then difficult to balance a valgus knee? There's less space to work on the lateral aspect, number one. And LCL is not like your MCL where you have a superficial and a deep part and it's more forgiving to be releasing from the tibial side. It's a very flimsy structure. It's just like sheet-like thing. And even if you release or inadvertently cut it, you're not going to get much out of it if you're especially working on the tibial side. And then you have to deal with the attenuation of the MCL. Sometimes it's so lax that whatever you release, you probably end up having an unstable situation than being able to do a TKR. And there is definitely the hypoplastic bones or deficiency of the bones. Then it suddenly becomes a very kind of revision kind of scenario where you have to take in different kind of implants and keep your wedges, augments, and stems standby. So what do? You examine your patient in the in your OPD and then again on the table under anesthesia. Then what do? You see if the valgus is disappearing on flexion, or is it being correctable, or how much you are able to exaggerate the deformity. Then that will tell you the status of the MCL. If in case on reducing or on flexing the knee, if your valgus is reduced, then probably you know that the LCL is okay and you can do it like any other regular knee, and that's not much difficult to handle. But it doesn't disappear on flexion, then you know there is a deficient femoral condyle, or then LCL is very much contracted and tight. Now, classification, there's various ways of classification. This is more of a working classification as given by the International Society of Technology in Arthroplasty. It's divided whether the deformity is arising from the femoral component or the tibial component. The valgus from the femoral component. If the valgus is only seen in extension, then it can be either F1 or F2, or I mean F1A or F1B, intra-articular and extra-articular. If it is an extra-articular because of some deformity or a fracture or malunion, then you know that the LCL is okay. But if the valgus is there in both flexion and extension, which is the F2 variety, then you know that the lateral femoral condyle is dysplastic and the lateral structures are very tight. Now, the tibial side deformities. Whether it is intra-articular deformity, then you know that the deficient lateral tibial plateau, and extra-articular deformity, like it can be a iatrogenic also, a post-HTO kind of scenario. There can be a fracture or a shaft deformity as well. Now, clinical this thing, A mild variety would be, or type 1 would be anywhere between 5 to 15 degrees of valgus. 0 to 5 degrees, many a times we see that normal people, especially thin people, you'll be able to see that they have about 0 to 3 degrees or up to 5 degrees of valgus, which is quite natural. So we don't consider it to be a valgus deformity, it's normal. So in milder varieties, we have about 5 to 15 degrees. So minimal tissue release and we can get away with our regular implants. Even probably I would do a CR, happy to do a CR in this kind of situations. In moderate deformities, which is there between the 15 to 35 degrees, especially if there is no flexion contracture, then femoral soft tissue releases from the lateral femoral condyle should be, we will be able to get on with this. Probably we would like to substituting kind of implants in this. But in severe deformities, which are more than 35 degrees, on those associated with flexion, have to do a soft tissue releases from the lateral condyle. We have to do osteotomy if required, advancement of the MCL, or probably go for a constrained hinge kind of process. Now, too vigorous of soft tissue releases might require constrained implant. So you have to correct the deformity, but losing your stability. So this is what happens if you do not understand and try to deal knee like a varus knee and then go about doing our implantation. And we have to know the pathoanatomy. We have to understand the structures that are there on the side which are contracted. So there are 5 stabilizers side. In extension, in addition to the lateral gastrocnemius tendon, lateral collateral ligament, posterolateral corner, popliteus tendon, ITB is also crossing the joint at 90 degrees perpendicular. So that also acts as a stabilizer on the lateral side. In action, the ITB becomes parallel to the joint and it becomes ineffective. The knowledge of this, so when you're trying to balance your knee, you would know what structure to touch and what not to touch. Because if you were to try to correct the flexion space, and then if you're trying to look at the ITB, you wouldn't achieve much. But in extension, it will definitely of much use. The PCL, of course, in a valgus knee is attenuated with the MCL and it's of no use. So probably you should be relying at looking at posterior PCL substituting implants. The type of prosthesis selection that we do are variant 1, which is between 5 to 15 degrees. You can use a cruciate retaining or a substituting implant. In type 2, definitely a posterior substituting. In type 3, you can use a posterior substituting, but little more constraint to be needed and always have a backup. Approach, I do a medial approach most of the times, but only thing you have to remember is you limited medial dissection. Do not do any releases on the medial side at all. Just to get your tibia right in front to do a proximal tibial cut. In spite of doing a large retinacular releases on the lateral side, you can still safely close it. But sometimes the only argument against a medial approach in case of severe valgus deformity is that you may not be able to access the lateral structures. So there is also called lateral approach, and this has been described by Dr. J.V. Srinivas. Now let's go to the balancing. So I'm going to talk about the Ranawat technique of balancing in a valgus knee. He says tibia cut always first, then balance the knee in extension first by doing soft tissue releases, and then go to the balancing of the flexion space. And at this particular time, you might want to adjust your femoral cuts as well. Tibia cut, as I said, no medial release or very minimum medial release just to get it anteriorly so that you can do your this thing. And don't reference, like what you do, you reference and take about 6 mm, 8 mm or whatever, 10 mm you take out from the lateral tibial plateau. If you do that, in this case, you'll end up with a large flexion and extension space. So you would want to just take a minimal cut, scrape the lateral aspect. If needed, if your space find that it's tight in both inflection and extension, you can always go back and take 2 mm more. But majority of the times, just try to scrape the lateral aspect. That should be fine. Probably you will put your reference onto the intercondylar notch and then or eyeball it and just take a minimal cut. 3 degrees of slope is what is normally recommended. And even if you see a lateral tibial deficiency, it's usually contained. Now coming to the next cut, which is the distal femoral cut, your entry hole for the intramedullary jig is the most important one. Normally, you draw your right side line, epicondylar axis, and then probably you make a center hole there in a varus knee routinely. But in a valgus knee, it has to be medial, about 4.5 to 8 millimeters medial to the center. And that I'll tell you is to get into the normal anatomy of the femur. And then in the valgus cut, normally it can be anywhere between 3 to 10 degrees. Usually we put a 5 to 7 degree cut. But in valgus knee, you have to correct the deformity. I use what is 3 degree. Lateral femoral condylar hyperplasia is present in severe valgus deformity. It exists both in the distal and the posterior aspects. So when you are trying to cut the distal femur, do not try to chase the bone or go to the defect. You just cut whatever is. Normally what you cut is about 9 millimeters based on the size of the implant you choose or the company, 8 or 9 millimeters. Make sure that you're not chasing whatever your reference of the medial condyle, you just go and cut that. The deficiency has to be augmented, but you cannot go to this thing. Unless in a rare case where you have a FFD associated with, and then probably you think that the extend space is tight, then you might go and cut a little more, 2 mm. But that should be always at the end of this thing. You don't want to elevate your joint line, especially in a valgus knee, which will cause a mid-flexion instability, distorting the kinematics, and that should be a disaster. Now, once you have your proximal tibial cut and distal femoral cut, you should go for your extension space balancing. You can use laminar spreaders, you can use your spacers, and just do a trial. And then after that, you put your laminar spreaders and remove all the osteophytes from the lateral aspect. Posterolateral capsule, and at this particular point, you can start pie crusting of the capsule. The pie crusting can be done with a 15 blade. I will show you the technique there. And you probably want to release the lateral retinaculum as well. You may not need to correct it completely, but you are able to get some amount of correction, and then opening on the lateral side, you will stop there and then go to the flexion. So this is the technique described by Clark and Scuderi. You use a 15 blade and then under vision by putting proper light and then making sure that your assistant in holding the laminar spreaders, you make multiple stabs in the posterolateral corner and the iliotibial band. So, and then you use your periosteum elevator or a small curved osteotome or a gouge and do the posterior capsular release. Then in extension, to get the extension space opening on the lateral aspect, you can do the ITB release from the graded ITB release from the Gerdy's tubercle. So once you have released and you see this kind of space when you put in this thing, laminar spreader, then I think probably that's adequate enough to do. You don't have to do any further releases. That's the popliteus. We'll come to the popliteus tendon at a later stage, but this triangular area and some encroaching onto the iliotibial band, this is where we do our pie crusting. Now then we go to the flexion space. Now in the flexion space, because sometimes the hypoplastic lateral condyle, what happens is if you were to reference it off, you would definitely end up going into internal rotation. So get your epicondylar axis, that is the most important thing. Get your epicondylar axis and make sure that you're cutting perpendicular to that. So to do that, to make sure that your jig is not going into internal rotation, you ask your company, they provide you with these lateral shimmies. You can use a osteotome, you can use a bone removed from the distal femur or the proximal tibia to build that gap and make sure that you're not going into internal rotation. That's the way you have to cut. It has to be always perpendicular to the epicondylar line. Posterior condylar line, we may consider in varus, but definitely not in valgus because of the deficiency of the lateral femoral condyle on the posterior aspect. And again, patellar mal tracking and notching are very, very important. If you do an internal rotation, you may stuff your medial space, but your joint replacement will be not possible. So epicondylar axis, right side line, and always any of these techniques to make sure that your rotation of the femoral component is right. And then again, now in extension, we can only do it by putting spacers or laminar spreaders. In flexion, normally recommended would be to put your trial implants and then do the rest of the releases. Now you have to look at the LCL. You have to release the LCL from the femoral attachment, and if needed, even in spite of that, you are still tight, probably you will go and release the popliteus. So most of the times by doing these things, you can achieve your flexion and extension space. But if you find that it is still tight, then probably again you'll go and release a bit of the iliotibial band. Probably relook at the posterior capsule. And in spite of all this, you're still not able to correct it. Then this is the time when, in very severe and complex cases, you want to do a lateral condylite sliding osteotomy. And even if that is not sufficient in very severe cases, probably you want to plan and do none of these procedures that we have talked about and directly go for a proximal advancement of the MCL. That's the lateral epicondylar sliding technique. So what you do is you take it with a good chunk of bone and let it slide down with the trial implants in place. And then when you are happy with your flexion and extension space, and then you go and fix it with a washer screw. Medial advancement of the MCL. I haven't done this particularly, but I have seen, I've worked with Jean Briard. He does it quite often. And then I've seen that that's the only thing he does. So in a valgus knee, instead of going about and doing, so he'll just go to the posterolateral corner, clear a bit of the osteophytes, but instead of touching anything on the lateral side, he would do this. Do very minimal releases on the lateral side. So normally after your distal femoral and proximal tibial cut, this is the kind of scenario you end up with. So once you release the LCL and the ITB, though you have larger spaces, they are equal on both flexion and extension. But using such large oversized polys, the other way of working around it, you might want to build up the femur by putting augments on the distal and the posterior aspect, getting it down using stems and putting regular polys. And if needed, you can always do a medial advancement of the MCL. Now there are various algorithms. What we described was the Ranawat technique. And then you have Whiteside protocol. He says release the LCL, then the posterior corner and ITP in that order. Krakow says iliotibial band, lateral collateral ligament, popliteal talon, and posterior corner. Everyone has this thing, but most of them, whichever order you do them, most of them, the lateral structures, they have to be released. And there's a huge study done by Krakow and Mialko. They said that all the structures that have been released on the lateral side, lateral collateral ligament gives you the greatest amount of correction. And then if you combine it with a graded release of the popliteus tendon and iliotibial band, most of the time, majority of the time, you should be able to correct a valgus. My preferred technique of doing this. I generally do the medial parapatellar approach, and if in spite of under anesthesia, and if you see that the valgus is correctable, but still a residual 20 degrees or more is left, lateral approach. Lateral approach I've only done once. It's like it takes a little time to get your orientation right, because all our life we have been doing a medial approach. Definitely posterior stabilized only, and I always keep a handy the constraint ligaments as well. I do the femur first. Surprisingly, yes, though I have educated and talked about Ravan's technique of doing a tibia first, that's the way I've been taught, and I'm more comfortable doing the femur first because now I don't have to do much releases or anything on the attenuated MCL on the medial side to do the femur first. As soon as you open the joint and avert or subluxate the patella, femur is there writing. So it's much easier for me to go and cut the femur and then have space for the tibia without doing any releases on the medial collateral ligament or very minimal releases on the medial collateral ligament. But it's a matter of choice. Then again, as I said, minimal tibial cut from the lateral condyle. Make sure that you scrape it. Once you put your spaces, if you're not happy, you can always go and cut a little more, but don't cut everything at one go. I just cut about 4 to 6 mm. That's the maximum I have cut. Tibial defect is usually contained. Then we go to the posterolateral corner, remove all the osteophyte and a little bit of crusting on the posterolateral corner and the iliotibial band. Then once we are happy with the extension space, then we go to this thing. We have to adjust the external rotation of the cutting block. Epicondylar axis is the most reliable thing. You have to reference it of the tibial cut also. Then we go about to balance the knee inflection. For flexion, I always use the trial implant, and then we go and start releasing the structures like LCL and popliteal from the femoral condyle. If it is still tight, iliotibial band is next and that we release. And then once we are comfortable that most of the times the surgery is done, and then we go about with the implantation. But if needed, you have to always be well versed with lateral. You have to do a lateral condylar osteotomy or a proximal sliding one. You have to always have a plan before start of the surgery. Probably if you're already preoperatively planning a lateral sliding osteotomy, you might want not to really do too many releases or cut your LCL from the lateral condyle before you do this. And once you're done with all this, you have to make sure that when you're correcting huge valgus deformities, there can be always a chance of peroneal palsy. So after correcting it, post-operatively, probably you'll put a knee inflection with a pillow or a brace. This also helps you in releasing the order of things to do. It's a small thing for all of us to remember: osteophyte removal, capsular release, lateral patellofemoral ligament release, IT band release from the Gerdy's Tbl Cup, popliteus, lateral condyle LCL from the femur, intramuscular septum, of course the PCL, and biceps femoris from the fibular head, if needed. But when you're doing a biceps femoris tendon from the fibular head, you want to make sure that you're not using a cautery or isolating the common peroneal nerve and seeing it, and under vision making sure that you're doing this release. And probably with that, I'll end my topic. Thank you.
Thank you so much, Dr. Sai Lakshman. That was a wonderful talk on valgus knee. Now, the next talk is by Dr. Neelam Ramna. He has sent me a video. Now I'll start sharing his video because he could not attend. He has recorded a video. Let me start it. Can you see my screen?
Yeah, it is.
Yeah. So this is by Dr. Ramana.
Sir, is there an audio for this video, sir?
Audio, is it not very audible?
No, sir, it's not audible, sir. So, can you stop sharing the screen, sir?
Yeah.
Please stop share, sir.
Yeah.
When you again click on share screen, there is a small icon called optimize for video share. Please click it, sir.
Optimize for video share. Yeah, got it.
Yes.
Is that okay?
Yeah, please tick it and start sharing the video, sir.
Wonderful, wonderful. That's great. Is it audible now?
And prior to knee replacement, give a small presentation here.
Yeah.
Flexion contractures is a fairly common deformity that we see in knee replacement and prior to knee replacement. We have the most common being the varus deformity, and the next after that we see quite a few cases of flexion deformity. These deformities may be isolated of flexion deformity or a flexion combined with a varus or a valgus deformity. How to handle these flexion contractures during surgery and how to manage them is something that is very, very vital. Why does a flexion deformity develop? Normally, after a knee arthritic condition, pain is the first symptom patients come to us. They have inflammation, they have an effusion in some cases. And then with the flex position, which they go now for a period of time. Not doing physiotherapy obviously helps them to get the contracture faster also. The most pathological problem here is the posterior capsular contracture and osteophytes in the posterior femur and the anterior tibia. We have to classify the grades of FFD for us to treat it. We have classified them into mild, moderate, and severe. Mild deformities are less than 15 degrees, moderate deformities are 15 to 30 degrees, and severe deformities are more than 30 degrees. In mild cases, oftenly we can do with a primary knee implant. It may be either a CR or a PS, cruciate retaining or posterior stabilized implant. In moderate deformities, doing a cruciate retaining surgery is a little difficult, and we may need to use a posterior stabilized design. In severe deformities, often we have to use some form of higher constraint, or even in severe cases may need a hinge also, depending on the other deformities associated. Why is a flexion deformity so difficult to manage? It is difficult in an arthritic knee and in a post-replaced knee if you have left it in flexion deformity also. Why is this? Because the number of in the biomechanics, the quadriceps contracture energy expenditure required for a patient to ambulate with a flexion deformity is much higher. More than 50% energy expenditure with a bilateral FFD more than 30 degrees. Most of our patients being elderly are unable to walk with the pain. And if combined with a flexion deformity, they require an immense amount of quadriceps contraction energy expenditure for them to walk. Their walking velocities are slower, and obviously with abnormal gait mechanics and poorer functional scores. The flexion deformity often we see before anesthesia, as also we have to check the patient before surgery and also after anesthesia is given. Quite a few rheumatoid patients who have a little bit of muscle spasm because of the pain spasms, once the anesthesia is given, they become straight like in this picture here. So once it becomes straight, it's a fairly easier surgery to do, and we don't have to do anything extra than a normal knee replacement. The steps that we have to do for flexion deformity cases may vary compared to normal replacement. I'll just try to just give a broad guideline of some of the steps that we have to do initially. Now, we normally do a medial paraparatal approach. In certain cases, there is a stiffness of the knee and they do not fully extend. So obviously we may require a quadricep nip or a tibial tubercular osteotomy in rare cases, but most often we can get away with the standard medial paraparatal approach. In a mild case, we normally start with the standard resections. That means we take the standard femoral cut. The standard distal femoral cut that we normally take in any replacement is 9 millimeters. We would go ahead with the standard 9 millimeters and do the standard tibial resections. The first step which you would like to advise for people to do is in the femoral sizing. Now, this is the next step that is important here. Normally, in a flexion deformity, there is a laxity in the flexion space that arrives at the end of surgery. So prevent any flexion space enlargement and flexion instability. We always want to upsize the femur whenever possible. In a standard protocol, if the size comes in between two sizes, then we want to upsize the knee and use a higher size if it is possible. We would also want to reduce the tibial slope. Now, normally how much of a slope we are giving, we would not probably give excess slope, and make sure not giving excess slope in order to prevent the flexion gap from becoming larger. Once these cuts have been done, the next we go ahead is the medial-lateral ligament balancing. Supposing it is a varus knee, we would go for the medial release. In a valgus knee, we go for the lateral release, so go on and so forth. Once we have done this, then we look at the PCL and then take a call whether a knee is how balanced is the PCL tight. Does the PCL require any release? The PCL release can be done in two fashions. If you're doing a cruciate retaining knee, one is using two osteotomes and putting it into on the tibial just anterior to the PCL and making a V cut out there. With that, the PCL will get released. And some people also use it with the electrocauteric, where you use the anteromedial fibers of the PCL are released from the femoral side. Both methods can be done depending on how comfortable you are with the cruciate retaining knee. The next important step, once you have done all your cuts, is to remove all the posterior osteophytes, both in the femur and in the tibia, and also clear up the whole posterior space. The whole posterior condyles, posterior part of the tibia is filled with osteophytes. Those have to be removed. Here you're able to see a picture here how the posterior capsule adherent to the femur. So we have to take a curved osteotome and release it here all the way up in the posterior part of the femur and the gastrocnemius also in a flexion deformity case. With the release of this, it will aid in your extension space balancing, and an extension space will be enlarged. In certain severe cases, we also end up doing a tenotomy or a transverse capsulotomy. Here you're able to see where we're able to, this is requires a little more experience, and after a certain period of time, you'll be able to do it carefully, protecting the posterior vascular structures. You'll be able to transverse capsulotomy at the joint line, at the tibial cut area. Next, we come to the bone resections. Once you have done your balancing mediolateral, you have done your PCL release, depending on that, then you go to the bone resection in case we need to do an additional bone resection. Now, as I mentioned earlier, the most common deformity we see, most common problem we see in a knee replacement is a tight extension gap. So when we have an extension gap that is tight, which I'll show you in the next slides also, we have to do an additional 2 millimeters or 4 millimeters of a recut if the knee is not in straight extension. Even after the releases, if not an extension, we can initially do a 2 millimeter extra cut to aid us increase the extension space. We technically can increase the cuts further required also, but we would advise you not to do it in the initial step, and if required, we can go back to the cut later again. Here you're able to see, this is the knee femoral implant, this is spacer block inflection. Whereas a spatial block, if you're putting an extension, it is becoming tight and it's not extending the knee fully. So in order to increase the extension gap, what we are doing here is taking out additional bone from the distal femur. We take out normally in the initial step anywhere between 2 to 3 millimeters, and then if required, we can extend it a little. Once we take out the distal femur, we're able to see the knee has become straight. So this is the basic bony cuts that we do in a flexion deformity case after the primary releases haven't worked. Bony resections, increasing the distal femur, increase the extension gap. This does not affect the flexion gap and does not result in any flexion instability, only if you cut the distal femur. Now, in the same place, if you hadn't cut the distal femur and instead of cutting the distal femur, if you had cut the proximal tibia in the same situation, you will increase both the extension gap and the flexion gap, and this is not desirable and it will require a flexion instability. You will have a straight leg because you've cut the tibia and increased spaces both ways, but you'll have a flexion instability, and that is not at all warranted. Most cases that we see, we don't only see a flexion deformity, we often see a flexion varus or a flexion valgus deformity. In these cases, we have to do the deformity correction along with the varus release also. So if the varus deformity is there, we do a posteromedial capsule release from the tibia and also probably release the semimembranosus also. In a valgus deformity, we do the posterolateral corner and the posterior capsule also laterally. This is fairly adequate if you can do it in mild to moderate cases, but in moderate to severe cases, we have to do the next level also. We often cannot do a cruciate retaining knee in these cases, and we'll need to convert it to a posterior stabilized knee. In certain cases, once we do a posterior stabilize also, in the moderate to severe cases, we cannot balance the knee with just the regular constraint of a PS box. We may have to use a TC3 or even keep it in severe cases, a hinge also ready. Once all the releases are done, there is certain cases where we had to do the posterior hamstring release with a Perkett NS stenotomy. Here you're able to see a patient who has a flexion deformity preoperatively. This is on the table after anesthesia is given. There is easy. Operatively, you're able to see we have got the leg straight. How do we assess whether the leg is straight on table is something that we can do some procedure like this. That means we make stand at the end of the table, dorsiflex the ankle, and keep the leg fully extended and give axial pressure from here. Once we give axial pressure from the foot end, if the knee flexes when we're doing this, that means we still haven't corrected the flexion deformity. Whereas if it does not flex when you're giving axial pressure and extension, that means that we have achieved adequate extension. In a thin patient like this, we can often gauge the full extension by actually seeing the case in the leg. But quite often obese patients, we often miss it because of the adipose tissue. Another important thing is what we tend to do as surgeons, and all of us have done it in our practice, is when putting pressure onto the knee while the cementing sets with the setting. This is something that we should not do, and we should get full extension on the table when we are doing it in the when we are cementing it also. This pressure, when we put it, often when the patient goes out of anesthesia and goes into the post-op ward, you will see they're getting it back in 5 to 10 degrees flexion. Now, these are some difficult cases we have done. You're seeing here a 90-degree deformity. Well, post-operative, we're able to see we're getting at least around a short of 10 degrees, we're getting full extension. So these are fairly difficult cases which cannot be done only into one cut. We need to reassess at multiple stages, and at least 5-6 recuts may be required. Different balancing methods are required based on the following principles we are talking. Here you're able to see the same knee that we had done, extensive post release. You're seeing a larger flexion gap on this photo on the left side. Whereas you see the extension gap, we are hardly getting any extension. That means our flexion gap probably is looking at this much. The extension gap is hardly anything. In these cases, we have to release the posterior capsule, gastrocnemius, posterior part of the tibia also. The posterior tibial capsule also has to be released. Capsulotomy needs to be done for the posterior capsule, and distal femoral resection. How much can we resect the distal femur is what we have to gain with experience. In my practice, I have done easily up to 4 to 5 millimeters without a major instability problem, and beyond that, it will cause a problem. So post-op care in all these cases of flexion contracture is very, very important. You have to emphasize keeping the knee extended. Patients should not be used to putting a pillow underneath the knee. That is the first thing the patients do because they're comfortable keeping it in a flex position, and they will put a pillow underneath the knee, and this aids to the it makes the life for the physiotherapist much more difficult, and they cannot get you full extension. Pain control is an important aspect. So most often all our patients get a periarticular infiltration, and in some cases if required, they get a femoral nerve block also. Splinting with a knee immobilizer or a hyper extension splint is something that I routinely do for all these patients for the first 1 week. They're made to use the extension brace all through day and night, but make sure you do not put it too tight because you can develop a skin necrosis. If the patient while walking has the other leg that has not been operated and there is a shortening of the other leg, then we need to correct the heel raise. Once we correct the heel raise on the contralateral leg and make the whole sole higher, then the deformity on the operated leg becomes less. Most often patients in moderate to severe deformities have an extensor lag that requires a little longer therapy, and they all do recover in the next 2-3 months. What we have seen in studies has been conflicting. We have seen surgeons telling us that a flexion deformity on table, if it is there and left behind post-op, will always persist. We have both side studies, and it has to be dependent on how you practice and how you see it in your personal practice. There is a significant association between flexion the first study in JBGS in 2008. A significant association between flexion contracture and anterior knee pain was observed in those even with patellar resurfacing. That means if you leave a 10-degree deformity and make the patient walk post-operatively, even if you resurface the patella, there is a high chance of him getting anterior knee pain. So deformities are not tolerated well in most of the patients. Flexion contracture, that in the next study in Journal of Arthroplasty, flexion contracture persists if the contracture is more than 15 degrees at 3 months after total knee replacement. So that is a significant contracture after 3 months, and the chances of that recovering are slim if left behind. This is another study with a natural history of flexion deformity following total knee replacement, a prospective 5-year study. We have shown that it is study in another JBJ study in 2005. We have shown that gradual improvement in the knee extension can be expected after 3 years after surgery with FFD. By the time the residual FFD is mild or absent, and the majority of patients, including those who have severe pre-operative FFD, do settle down. The second paper is another one in COR, in the knee journal. Flexion deformity following a total knee replacement, a prospective study of natural history. Gradual improvement of FFD can be expected for up to 2 years, and a small residual flexion contracture does not cause a functional deficit. So we have different papers from different publishers showing us how a flexion deformity can improve with time or may not improve with time. So in my opinion, what I would like to tell you is the elderly people who are above the age of 70, 80, they do not cooperate with physiotherapy, and if they have a lot of pain post-operative, not controlled well, even a 5-degree flexion deformity that you leave on table can progress in 3 months to 15 degrees. So what I'd advise all youngsters is they have to have a fully straight knee in case of an osteoarthritic knee, and do not accept more than a 5-degree flexion deformity. 5 degrees can be managed with physiotherapy, splinting, but anything more than that, patients do tend to complain a lot, and they tend to increase the deformity over a period of time. The complications that we have seen following knee replacement with these cases are, in the severe cases, we often see a flexion extension imbalance. There is obviously an imbalance, and we tend to accept it to a certain level. If it is more, then we have to either use augments or do other methods. Patella baja occurs because of additional femoral resection. That means a joint line alteration. So when we change the femur, we are altering the joint line. So it keeps on going up. We get a recurrent flexion contracture. There could be a peroneal nerve injury that occurs. All these are complications that could occur, but we don't commonly see them. The only important thing that we see which with the patella baja is probably having a mid-flexion instability. Well, that has to be attended to on the table, and additional excessive femoral resection, not balancing the knee with soft tissues, can cause you to have a problem. So first do soft tissue release, get all your releases completely, both the medial lateral, posterior capsule, gastrocnemius, and then do additional resection of the distal femur if it's not straight. Recurrent flexion contractures have not been very common because we are fairly aggressive with our physiotherapy and keep monitoring the patients. Such patients should be called out OPD regularly at suture removal at 20 days after surgery. If you leave them, say suture removal, come back after 3 months, they will come back with a much severe deformity, and then you cannot do anything at that point of time. Physiotherapy so late may not be helpful. In conclusion, choice of implants, CR, PS, constraint or hinge. So a CR implant is a cruciating implant, which in my practice has worked in significant number of cases. In a flexion deformity case, if the deformity is more than 10 to 15 degrees, I would probably not use a CR implant. I would go for a PS implant. With the release of the PCL and resection of the PCL, the balancing becomes that much easier, and we don't have to have another issue of balancing with the PCL also. In little more severe cases, when we do land up with some instabilities, we have to increase the constraint and either use a TC3 implant or an hinge implant. Joint line elevation, we have discussed quite a lot. Additional 2 millimeters resection is acceptable. I would go to 4 millimeter also if required in moderate to severe cases. But beyond that, I'd be cautious and recheck my patella and how the midflexion instability is occurring. Mandatory to get a straight knee in elderly and not so active patients. There's no compromise on this because they are very weak and don't cooperate well with physiotherapy. Rheumatoid patients, I would accept a 5 degree deformity even on table also. These patients do tend to stretch, and we have had satisfactory results with these patients, even if they have had a slight flexion deformity immediately post-op. Post-op rehabilitation is essential in these cases. Extensor lag has to be addressed with aggressive physiotherapy. Splinting and extension is important, and that can be, I usually do it for the first 5 days to a week, and after that we give them a night splint. Most of these patients we have seen develop a deformity when they sleep in the night with the legs folded. So night splinting I would continue till I'm totally comfortable, and daytime splinting is for the day and night splinting for the first 5 days to a week. Thank you. Conclusion is get it straight.
Thank you, Dr. Neelam Ravana. Now, okay. Can you hear me?
Srinivas, you're audible.
Yeah. So now I request Dr. Ali Mehdi to talk on pain management protocol to early postoperative recovery in total knee arthroplasty. So over to you, sir, Dr. Ali. So we are, it's not audible. You have to unmute.
Good morning from Scotland. Can you hear me?
Yeah.
And
please share your screen.
Yes, hello, and a very good morning to you across Telangana. I'd like to thank you, Dr. Srinivas, for inviting me. I'd like to thank the Twin Cities Orthopedic Association and the Telangana Orthopedic Surgeons Association. And above all, I'd like to thank everybody in the audience for giving me the opportunity to speak to you about the pain management protocols that we have been employing in my practice for the last 10 years. So I'm very much a Hyderabadi by heart, even though I live in Scotland. Let me just share some slides with you. I'll also share a video in the middle of my presentation. Sure. Can you see my slides?
Yeah, it's just starting up. Yeah.
Perfect. So I've been a consultant where I practiced for the last 13 years. You can see that this is how, 1 minute, let me just put the screen share on. Yeah, there you go. So I practice in a 260 bedded hospital in Scotland, and you can see these are the key members of my team with whom I implemented enhanced recovery in orthopedics. So I think it's very important at the very outset to say that to have good pain management, you need to have multidisciplinary management. Our pain management protocols or enhanced recovery after arthroplasty surgery were derived from the work of Henrik Kellet, who is a surgeon based in Denmark. And from him, the Golden Jubilee National Hospital in Scotland was the first organization in the UK to implement enhanced recovery after arthroplasty surgery. There is some literature on enhanced recovery after arthroplasty surgery, but on the whole, it is fairly limited. But I thought these were quite useful papers that a lot of people in the audience might be able to have a look at. So I'll just stop here briefly, and I'll show you a video about the project that we implemented a few years ago. Please bear with me.
I think you have stopped sharing.
No, I'm here. Right, there you go.
Yeah.
So remember, heels of the hands on the arms of the chair. Okay, and then Mary Upton has just had a hip replacement. Just pause a moment just to let you, but she's not allowed to lounge around in bed. She's encouraged to get up and walk. Okay, so in your own time, both sticks forwards together, right leg, and past it with the left. Perfect. I didn't have any pain, but it's slow, and exhausting, and they don't push you too hard the first time. They do push you later. I was glad to get onto my bed afterwards. Pat Mackenzie is about to go home, having been in hospital for just 3 days and already climbed a flight of stairs.
And that's all that's required for going home. The rest of it is up to me. I have to do exercises at home. Very concentrated, hard exercises, I might say.
You'll be totally pain-free. Key to all this is making sure patients aren't in pain, and a local anaesthetic is the solution.
We give preoperative drugs, but other than that, we put local anesthetic injections into the hip or knee, depending on what we're doing. And for the knee, we have a special pump that infuses the local anesthetic fluid for up to 24 hours, and that's what makes people walk on the day of surgery.
This hospital used to have one of the longest recovery times for hip and knee surgery in Scotland. Now, it's got one of the shortest.
And it leads to less complications such as deep vein thrombosis or pulmonary embolisms. Earlier discharge, patients are more satisfied, and it generally makes for better outcomes for everybody concerned.
Now, Pat is looking forward to countryside walks, and Mary says her new hip will help her get back on the golf course.
Amazing. That's all I can say. It's an amazing place.
Eleanor Bradford, reporting Scotland.
So thank you very much. I hope you understood the Scottish accent. I'll just put my video, my screen share back up. There you go. So in there, you saw there was a patient who had a knee replacement, and we actually did see a major paradigm shift in our practice. So the Caledonian technique is the key for this whole process of pain management and early recovery. So to break it down, it's clinical attitude leading to early discharge. So that's what Caledonian stands for. Caledonian, of course, also is another description of Scotland. But it doesn't come so simply. Like I said to you, you need a whole team, a team that helps you through the entire process. So the main pillars of enhanced recovery after arthroplasty surgery is you need to be able to speak to the patients in outpatients when you're listing the patient, and there's a whole other series of steps that I'll cover in the course of this presentation. So realistic medicine is a system that has been in wide use across Scotland for the last 7 to 8 years. It is about shared decision-making. The system also exists in Canada. It's about good patient education and for patients to ultimately decide if or not they want the surgery. So when we speak to a patient who is due to have a knee replacement, we discuss with them what the options of treating knee osteoarthritis is. Our focus is purely on pain management. So of course, everybody in the audience will agree that a knee replacement is done for pain relief. It is the last resort for pain relief. So when somebody has tried analgesic drugs, exhausted physiotherapy, it is their decision. Or in fact, practices, it's their decision for whether they want or not a total knee replacement. When they decide that they want a total knee replacement, or even before that, we discuss with them the 80% chance, meaning 80% of people who have a knee replacement according to National Joint Registry figures, and of course in our own practice, derive satisfaction. 20% of people either continue to have pain, and in amongst that figure, we've got 5% who have a complication. So we discuss the potential complications and the implications of the complications quite extensively. And ultimately, it's their decision whether or not they want to have a knee replacement. The vast majority of people are quite severely disabled when they present to us. And it is their decision to go ahead with the knee replacement. And we discuss at the very outset that they will be in hospital for a certain number of days. So previously we'd say 3 days, but now we say 2 days for people under 70. People over 70, the reality is that it could take between 5 and 7 days for them to be discharged. As part of the outpatient scheduling process, we also have self-assessment forms where patients fill out any symptoms, list out the drugs that they're on for any ongoing medical issues. And then we make that referral to the perioperative team. So the perioperative team comprises nurses, but you can see that the gentleman on the right of your screen is an anesthetist. So anesthetists are absolutely critical because they understand medical problems more than we do. They manage the patient through the operation. They're effectively co-navigators with you. They are your help. So John Antiposter, the man on the right, he was instrumental in developing our protocols, our medical protocols for patients undergoing hip and knee replacement. And even then, the nurse, the perioperative nurse, and the anesthetist are critical in promoting that clinical attitude that will tell the patient that during surgery, they will be given full forms of pain relief, and then they'll be in the hospital for 2 to 3 days, no more than that. The promotion of clinical attitude continues. So our preoperative patients attend a physiotherapy-led knee school. So they're shown all the exercises, they're taught to mobilize with crutches, elderly patients are taught to mobilize with a Zimmer frame. They're seen by an occupational therapist. Now, for some of you in the audience who doesn't know what an occupational therapist is, these are healthcare professionals who assess patients for their daily household needs. So for example, they will give patients who are not able to rise from a standard chair, a raise, a cushion. In the West, of course, you've got WCs. So these patients are provided with raised toilet seats, and they're also assessed whether they would have to be able to whether they'd be able to manage by themselves or not. Because, you know, in the West, unlike in India, but increasingly so in India, we're finding that patients are living by themselves and they require support. So those sort of assessments are made, and the patients are given a booklet. And the booklet, I mean, if you have time, I might just share the document later on, has instructions, it has the details of the operation, details of physiotherapy that they've got, patients have to do, and then the potential complications, just to reinforce to the patient the journey that they're embarking on, so that they are absolutely certain that they want to have surgery. And if they do want to have surgery, to have that correct attitude to managing their pain and discharge. So all our patients are actually admitted on the day of surgery. And the pre-med, they get a pre-med comprising neuropathic drugs such as pregabalin. Patients are given dexamethasone, and I'll talk about a little bit about dexamethasone later on in our talk. Patients who are diabetic have their blood sugar measured. As a pre-med, they get oxycodone. We make sure to stop ACE inhibitors, meaning, you know, enalaprils and the likes of that, and then angiotensin receptor blockers such as losartan. Until 2 hours before surgery, patients are given clear fluid, usually carbohydrate-loaded drinks, but again, in diabetics, we give them water. And they're walked from the ward to theatre. In theatre, the anesthetist will give a spinal anesthetic, but patients with spinal stenosis or who've had back surgery tend to get a general anesthetic. And I'll again, you know, cover a certain aspect of the general anesthetic. So the spinal anesthetic is 0.5% bupivacaine. Previously, before we implemented enhanced recovery, we used to give opioids in the spinal anesthetic. Opioids, we found, provided prolonged blockade, nerve blockade, but they also caused orthostatic hypotension, and these patients required intensive monitoring in a high dependency environment, but they also required, by and large, huge volumes of fluid and very often blood transfusion. So the operated patients given the spinal anesthetic on the side, the operated leg is kept up so that there's a transfer of the local anesthetic effect to the operated leg. In the past couple of years, the anesthetists have started giving adductor canal blocks, which provide excellent analgesia, intraoperative analgesia, particularly all the way across the front of the knee to the side. So the only area that's not covered is the posterior capsule and the posterior aspect of the knee. Other drugs given are ondansetron and then COX inhibitors. Some patients choose to stay awake and they listen to music with the headphones. I suppose in the Indian context, they'd listen to religious music or I suppose prayers. But in the Western context, it's usually music, but some patients do not feel that they're able to tolerate the sound of power tools, so they're asked to be given sedation. So they're given propofol, ketamine, but only on request. Now, I operate with the knee flexed. As I enter the knee, I achieve hemostasis. I use a cutting diathermy to do my medial release. Some excellent presentations early on stressed on limited releases to begin with. But during the operation, we use 0.2% ropivacaine. I know that in India, when I've operated, you have 0.75% ropivacaine. You can achieve a dilution with 7.5% ropivacaine. You can use a maximum of 40 ml, but you can actually add normal saline to make it up to 120 degrees. So we inject 0.2% ropivacaine at 5 points. So in the middle of the knee, the posterior capsule, again, you need to make sure you're aspirating. Then on either corner of the knee at the back, and then a point in between. You have to make sure that you're aspirating. So that provides excellent blockade to the back of the knee. It relaxes the hamstrings for post-operative mobilization. And we give tranexamic acid. So my practice is to let down the tourniquet as soon as the knee replacements have gone in. And the tranexamic acid provides excellent hemostasis. So again, after letting down the tourniquet, good hemostasis means that we do not require the use of drains. In any case, the literature shows that patients who have drains versus no drains, the complication rate, the wound breakdown rate isn't any different. In fact, it's found that with not using drains, the infection rate is less. Before we implemented this protocol, like I said, our patients had spinal opioids. So they required urinary catheters, but now they don't require urinary catheters. We limit IV fluids to less than a liter. What you see on the picture to your right, or the first picture with the man standing, is a golden jubilee dressing. It is it's composed of a substance called duoderm. It's very stretchy. It sticks very nicely. It can stay on the knee for 7 days. It provides a very tight seal, but more importantly, it allows the knee to flex and it prevents any leakage of blood. But there are some patients, particularly in our practice, we have noticed that patients with a body mass index of over 30 tend to have leaky wounds. So you'll see a picture, the picture on the top right corner of the screen is of a Pico dressing, which is a suction dressing that provides a tight vacuum pack to the knee and prevents any leakage of fluid. Because again, in our practice, we have seen that leaky wounds have a high association with postoperative infection. After the hemostasis is secured, in fact, in more recent times, I have stopped using any bandage. So I leave a dressing on. My principle is that if somebody's had abdominal surgery, you'll not tighten the abdomen with a pressure pack. You want to see if there's any bleeding. Because again, in recent practice, if somebody continues to have a leaky wound for over 48 hours, we will take the patient back and evacuate the hematoma and secure hemostasis, because again, we have found that that reduces the infection rate. So after the patients had surgery, they're transferred to the ward on trolley. They do not go to the intensive care unit. They're kept in a multiple occupancy bay. What we've found, across the UK where enhanced recovery has been implemented, having another patient who's had a similar operation actually encourages both patients to mobilize quickly. Effectively, there's a bit of a competition to see who's going to be bending their knee the most, mobilizing, and then going home the earliest. So we have found that that builds up, if you like, support amongst patients. And I totally understand in India, the context is entirely different. People prefer privacy, they like their own rooms. But in the West, that's how it works. We make sure that the patients are not connected to any trips. It's been seen that patients being connected to trips actually hinders mobilization. And we call that pajama paralysis. So on the day after surgery, we actually get them changed into their own clothes. Our blood transfusion rate has dropped. We only give patients a blood transfusion if they've dropped their blood pressure and the hemoglobin is less than 8, particularly if we have found that they've had intraoperative blood loss excessively. So we mobilize our patients on the day of the operation. So you can see the lady on the left. She's had a hip replacement. She's not had a knee replacement, but it works the same for a knee replacement. And you see the man on the right. So this is an operation that I did in India, and even in the Indian context, it is possible to encourage patients to mobilize. But of course, this is a young man as against an elderly patient. What we found when we started the enhanced recovery technique was that we used to use a balloon pump with local anesthetic, and that's what you saw in the video. We used to infuse it with more ropivacaine, and that would be instilled into the knee cavity. So again, we wondered, was that necessary? So we trialed whether just using infiltration as against the balloon pump would be necessary. So apart from the cost saving, our concern was that leaving a drain in the knee for 24 hours could potentially introduce infection. And we actually did find that infiltration alone without the balloon pump worked. So we only infiltrate the knee during surgery, and that provides for up to 24 hours of pain relief. And as a result of that, when patients are mobilized and when they sit in their chair, guess what? The knee bends to 90 degrees. And that was one of the biggest changes that we found. So if you infiltrate the knee during surgery with ropivacaine in the posterior capsule, and if an adductor canal block is used, that's enough. But if it's not used, if you infiltrate the quadriceps mechanism and the skin, you will find that the patient is completely pain-free. And rather than you having situations where either there's a nerve blockade causing quadriceps inhibition from a nerve block, or for that matter, if the patient's in pain but they're not able to mobilize the knee, they automatically bend the knee to beyond 90 degrees on the day of surgery, which reduces the physiotherapy input. They're mobilized to the toilet, and like I said before, they're in their normal clothes. And they get, again, a cocktail of pregabalin, of COX inhibitors. Of course, with COX inhibitors, you've got to be careful. Some people have underlying cardiovascular disorders that can increase the risk of myocardial infarction, so it has to be given with caution. And the patients with pre-existing renal impairment as well require caution with that. We give thromboprophylaxis in the form of deltaparin, and on discharge, we have started giving oral anticoagulants. So apixaban, 2.5 milligrams, 2 times a day. The immediate effects of enhanced recovery, and you know, these results still stand true, is that only a very few number of patients, or very few percentage of patients, require a blood transfusion or catheterization. The majority, the vast majority, mobilize on the day. Our hospital was able to save up to £10,000 per patient because we moved away from the practice of admitting people into intensive care for high dependency. And the patients had a much better journey, and they require less physiotherapy. We used to have the highest length of stay. We used to have the highest time to discharge. And with the enhanced recovery program, we were the first hospital, in fact, general hospital in Scotland after the Golden Jubilee Hospital to implement the program. Our length of stay became the best. One of the things we also learned very quickly was that it doesn't take a physiotherapist to mobilize patients. A nurse can very safely mobilize a patient who has had a total knee replacement. It takes a little bit of training, but on the whole, if you give them the confidence, they will do that for you. And we consistently maintain the lowest length of stay from excellent pain relief, even over a 7-year period. So there are challenges. It is a multidisciplinary process. Getting everybody to align to your way of thinking is difficult, but it has to be a process that is adopted across your department, adopted as a culture. Otherwise, you will find that if surgeon X practices this and surgeon Y doesn't, there's confusion. Nurses and the other staff do not know what to do. A big challenge that we noticed was orthostatic or postural hypertension. So patients, for a start, have less fluid, they are taking opioids, and as a result, they can feel dizzy. So even then, we avoid the tendency to give a blood transfusion. We give an IV bolus of fluid of 500 ml and ephedrine. We noticed over a period of years that a group of patients were developing renal impairment, particularly patients with pre-existing high levels or high creatinine, baseline creatinines. I'll come to that in a minute. There was also a concern about infection. Were the drugs, particularly dexamethasone, causing an increased rate of infection? Elderly and frail patients, and of course there are cultural barriers to some patients wanting to be discharged early. One thing, particularly with knee replacements, that has been fairly consistent is that after 24 hours, patients get a sudden surge of pain. But with patient education, where we tell them, look, there's no harm in mobilizing, there's no harm in continuing to do your exercises. Yes, we will give you oxycodone, we will give you your painkillers, the pain will feel better, continue mobilizing, because if you don't mobilize, your knee will become stiff, your pain will continue, and you will not get a good result. By that sort of education, the patients actually do continue to mobilize, and we do find that the pain often resolves in about 12 hours. But we do get this surge of pain after 24 hours because the local anesthetic wears off. So going back to this issue about infection, when we first started out, you'll see on the graph on the left, our infection rate was amongst the lowest in Scotland, but it has crept up slightly. We did have a slight surge of infections in one particular year that was 3 or 4 years after we started the enhanced recovery process. So some people might argue, in the pursuit of pain relief, where you're giving dexamethasone, a corticosteroid, are we increasing the risk of infection? We did some detailed studies into that. What we actually found after we stopped giving dexamethasone, so we did stop giving dexamethasone, was that the pain levels went up dramatically. It did not make any difference to the rate of infection. So dexamethasone is absolutely critical, because you've probably seen again, in some kind of general practices in your own environment, patients get dexamethasone for pretty much everything. Dexamethasone is a mood elevator. So I remember going to another country, I was running a camp, and over there were patients who had colds, coughs, fevers, and they kept asking for Ampoule, which was of course dexamethasone. So it's a mood elevator, but more importantly, it reduces swelling. And because of that, patients are able to mobilize the knee and they're in less pain. So we reverted back to giving dexamethasone, and very dramatically we found that patients with pain, the severe pain surges had decreased. Renal impairment is an ongoing issue. What we found was that renal impairment was linked to people with underlying renal impairment, but we moved away from our antibiotic prophylaxis protocol to being kept a single dose of cefuroxime only, to giving flucloxacin and gentamicin. And that with pregabalin and etoricoxib escalated the renal impairment rate. So we have continued with pregabalin and etoricoxib, but we've moved back to a regime of cefuroxime, and the level of renal impairment has actually declined. The other thing that we've moved on from is restricting fluid. So people with pre-existing renal impairment, we don't restrict fluid, and we do actually give over 1.5 liters of IV fluid, but we make sure that they're not actually hooked onto a drip, because our aim is to mobilize them. Another good paper, so this was a paper from Northumbria Healthcare Trust. Northumbria Healthcare Trust, if you want to look at their protocols, again, very useful. They are, if you like, leaders in this particular area of enhanced recovery. So they reported on over 1,700 knee replacements. And what they found was, as a result of the enhanced recovery process or this pain management protocol, the overall complication rate, particularly for myocardial infarctions, dropped. Apart from the fact that from a length of stay of 6 days, they dropped their length of stay to 3 days, very similar to ours. The overall satisfaction rate we found with patients was 90%. So again, you know, in the few cases I've operated on in Hyderabad, by employing this protocol, I have found that patients are extremely satisfied. It's about educating them. Pain can be very limiting. It reduces, it hinders mobility. It, in a sense, also, from a certain perspective, makes you anxious whether or not the patient is actually going to be satisfied or not. But with this protocol, we experienced a huge level of satisfaction, some very good notes, very good feedback. So most recently, in the past year, we have removed restrictions. So, but more importantly, we have reinforced, we've told patients rather than 3 days, you're going to go home within 48 hours. You have to move, you have to do as said. And we have found that we've successfully implemented in the under 70s a length of stay of less than 2 days. This hasn't increased the readmission rate for things such as infection, hematomas, leaky wounds, or DVTs. So what is the future? Now, interestingly, I read this report of day surgery, total knee replacement. If you look very closely at this lady's left knee, you'll find it's a full length incision. So this operation was done at Massachusetts, one of the hospitals in Boston anyway. And it was a newspaper report. I could not find anything in academic literature about day surgery, total knee replacement. Yes, there's something on unicompartmental knees. But again, what was interesting when I read the report was that it was about patient education. It was about creating an expectation that you will go home on the day of surgery. We will provide you with long-acting analgesia, but more importantly, to overcome the challenges that will prevent day surgery knee replacements, you need good domiciliary support. You need good remote nursing, physio, and medical access. Now, of course, with the COVID-19 pandemic, a whole range of video conferencing has emerged. So potentially you could have somebody with home monitoring connected on to some kind of telemetric system, potentially, but with minimum monitoring, the monitoring not required, even the argument for that would be futile. But you have Zoom, you've got various sources. The fact that I'm talking to you in India from remote and speakers from their home means that we are in the age where it is possible to monitor people from home. But of course, you require rigid governance, and there needs to be that cultural acceptance as well. So is this going to become the norm? Now, you might think that, oh no, it's not possible, because there's that cultural shift that we will all have to embrace. So Paul Krugman, a Nobel Prize winner in 2008, said in 1995, by 2005 or so, it will, or in fact, he said in 1997, just at the beginning of the internet era, that the internet's impact on the economy will not be greater than that of the fax machine. So there you are. There are lots of things that have happened in our own lifetime. We have moved from not having phones to having fixed landlines and to mobile phones, having one screen at home in the form of a television to about 15 screens in the form of phones, laptops, pads, etc. So yes, it is possible. So in summary, my friends, in summary, dear colleagues, you require multidisciplinary inputs into good pain relief to enhance recovery. Patient education is absolutely critical so that the correct attitude is built amongst patients. And the surgeons, of course, need to have the correct attitude, the correct mindset to be able to do that. And they need to show leadership. It's very important that you are leaders, your opinion matters. You need to take your whole team with you, which includes everyone, all the healthcare professionals around you, most importantly, your anesthetic colleagues. Yes, there are challenges to be overcome, renal impairment, frail elderly patients getting home the same day. And again, I would argue that it's absolutely critical for elderly patients to be able to go home, especially, you know, we live in the era of COVID. We do not want them to be exposed to any hospital-borne COVID, or for that matter, hospital-borne complications such as bacterial infections. But on the whole, enhanced recovery of good pain management reduces complications and enhances outcome. Can we do it? Yes, of course we can. And I leave you with a small note. You know, we do live in the era of COVID. There has been a lot of darkness around us, but in that darkness somewhere there's a glimmer of light. And I leave you with a view of my hospital and the cricket ground next to the hospital. I thank you very much for your time, and I'll be very happy to take questions during the plenary. I wish you all the best. Keep safe.
Thank you so much, Dr. Ali. That was a wonderful talk on enhanced pain recovery after total knee arthroplasty. Now, without any delay, we'll go with the next talk by much awaited Dr. A.V. Guru Reddy sir's talk, that is evolution and advances in total knee arthroplasty. Over to you, sir.
Srinivas, can you hear me?
Yes, yes.
I'm starting sharing the screen.
Sure.
Right, desktop. Share. Desktop share. How do I go to whiteboard, iPad, WhatsApp, desktop 1. Right, okay. Can you see that? Oh, this is not the one. Yeah.
PowerPoint open చేసావా?
PowerPoint ఇప్పుడు డెస్క్టాప్ మీద పెట్టాను.
అది ముందు ఓపెన్ చేసేయి.
అది డెస్క్టాప్ ఎట్టాలో తెలియట్లేదు కదా పాయింట్ ఆడ.
ఇదైతే మినిమైజ్ చేసుకో, ఇది జూమ్ స్క్రీన్ మినిమైజ్ చేయి.
జూమ్ మినిమైజ్ చేయాలా? రైట్, ఓకే. ఇది కూడా మినిమైజ్ చేయాలి కదా?
చేసేయి.
రైట్, రిమోట్ కంట్రోల్ ఆఫ్ యువర్ స్క్రీన్. లోకేష్.
So please accept it, sir.
All right, okay. Sorry, I said decline. I'll say approve. Okay, right. Take my.
Sir, sir.
Yeah, I got it.
Yeah.
Right. How I live live.
So you just click on the deny, sir.
Yeah, deny. Okay. Right. Go. Let me see the presentations. Okay, I got it. Presentations.
Click only once, sir, actually.
Okay.
Presentations, only one click.
Yeah, okay.
Yeah.
Evolution, got it.
Yes. Double click on it.
Yeah, okay. That's why I got a sunshine with me, Adarsh. But today he's busy somewhere else. Can you see?
Yeah.
Right.
But it is relax. So it's opening all the presentations, it seems. You have to check.
Oh, right. Oh, boy. There are a lot of.
Keep closing them, sir, better.
Oh, dear.
Yeah.
Dr. Ali, this is the technical handicap. So you got to bear with me. Yeah, I think
this is the one, sir.
Yeah, okay, right.
Yes,
but I have to close the others also?
Not required, sir. You can just enhance this.
Okay.
Yes, enough.
Right, okay. This enhance. How do you do that? Okay.
Lower right corner, yes.
Right corner, okay.
Yes.
Come on. Yes, we got it. Okay. Can you see me?
Yes, sir. Yes.
Right, okay. Good morning, everyone. It's a great privilege and pleasure to be with my friends, my once upon a time students, and my once upon a time registrars, my colleagues, and my UK friend, Dr. Ali. It's a pleasure to be with you all. And today I'm going to talk on evolution and advances in total knee arthroplasty. And so next 20 minutes, I'm going to talk about this thing. So who the hell you are to talk about this? People keep asking me. So I just put a small slide. It is not to boost my massage my self-esteem, but just to tell the perspective. 30 years I'm in the arthroplasty practice. That means half of my age. Now I'm 60 plus. So more than 40,000 knees done. And I got a complete documentation of the around 15,000 patients. Present, my load is around 4,000 knees per year. And I do around 12 different implant companies. All the implants in the world, you name it, we do it. So, and almost I trained more than 100, 150 fellows. Every year I got a 15 fellows. And Srinivas was my registrar, Ramana was my registrar, Lakshman was my registrar, and Somsekhar is my colleague. So many people are here. And so I've seen the technology evolve from 1980s. I've gone to England in 1989, and I remember my first knee IB2, and I did my first knee in IB2, and now it is 30 years since I started doing the knee replacements, and so I can talk about this. These are 20 years follow-up. The first IB2 I have done, some of the IB2s still going strong. So I would say there is nothing much to write home about the latest advance in knee replacement. IB2s, even the India knees, the INR knees, which have been done by Dolakyas and Lords and Sanchetis, more than 30, 35 years back are still doing all right. Evolution, I would put it in 3 phases. One is in 1800 to 1970. That is fraught with failure. From 1970 to 2000, reliability in fixation and survival of implants. That is the rule of the day. And 2000 to 2020, goalpost has changed. More than the survival, patient outcomes have become more important. And you can see with Ali's talk, they are very, very relevant. So now 1970, if you take the evolution from the first step of the ladder, the main challenge was inability to rigidly fix the implants to the bone. And then implants design were crude and engineering machining was poor, and most designs failed because of the engineering fallacies. In the sense, people did not understand the metallurgy, they did not understand the tribology, and they did not understand the kinematics also. So obviously it was a learning curve for all our forefathers. So basically you can see that 1860 resection arthroplasty for tuberculosis and skin, muscle, fat, pig bladder, ivory hinged knees, these are all met with doom. Then metallic process came, 1940, Campbell, relative success of the hip cup arthroplasty, Massachusetts General Hospital, it was done first time. And then hemiarthroplasties were done in 1958, not new, McKeever and McIntosh, but of course within 9 years, 8 years, those things happened. So those are all failures of the design, failures of the metallurgy. So then with the golden, I don't say golden era, a dramatic improvement happened between 1970 and 2000. I call it as innovation in design and fixation techniques. Acrylic cement was FDA approved thanks to John Charnley's hips, and better plastic was invented, and mechanics override anatomy and surgical techniques. So these are the evolution. It's a very busy slide, but to just concentrate on the come-outs is here. See 1971, left side is the timeline. Cement approved by FDA, and if you see here, total condylar knee, that is the IB2s from Ranawat and Insall and Burstein group. So you can see that Insall Burstein has come. Whereas in England, it's a Freeman Samuelson, and that has become a Freeman Samuelson. So these are the important landmarks. If you see both hips and knees, England has led than America. In fact, John Charnley was the father of hip replacement. Coming to see the knees also, you can see that 70s itself, Freeman from the London hospital has started doing this. So always UK was in the forefront. Freeman, the design objectives of the knee process, he envisaged some of the principles in those days. Number one, reduce friction, just like a Charnley's low friction arthroplasty hips. Even here also reduce friction, reduce constraint. Still though, they hold good. Rate of wear debris, we should be sensitive to that. And range of movement up to 90 degrees flexion. That's what he was targeting at that time. And resist freedom of rotation and soft tissue tension of the collaterals. Again, a good principle which is still holding a lot of water even now. And roller in trough concept. These are the principles laid out by Freeman in those years. Then Insall came, again a great surgeon and a great scientist and a great thought leader. And he in the hospital for special surgery, where Ranawat was his colleague. And in 1973, they started this cruciate sacrificing. At the same time, Dick Scott from Boston has started a cruciate retaining knee. That's why you got two different schools at the same time. So mechanics outweigh desire to anatomically reproduce knee kinematics. So Ranawat et al., 15 years, 94% survival. This is a benchmark paper in the arthroplasty literature. So basically what Insal, Ranawat and Bernstein taught the people of arthroplasty that, look, you don't need to reproduce the anatomical way a knee functions. You can go to the mechanical axis, like a perpendicular to the floor and all that, and get on with your knee replacements. And there is another philosophy called kinematic conflict has come into vogue. That means basically either articular geometry of implant must be free to determine how components move, or anatomic structures such as PCL must be allowed to pull the femur across the tibial surface. Basically, kinematic conflict is inability to serve two masters. So basically, it is like a round on trough, round on flat surfaces, vis-a-vis PCL presence or absence. If you see here, cruciate retaining TKA, if you see there, it's a round on slightly curved. An anterior stabilized knee, a constrained knee, and posterior stabilized knee, you can see cam engage is a post. So this kinematic conflict philosophy has evolutionized or put the CR and cruciate retaining and cruciate sacrificing knees on the table. If you see the design evolution from 1970 to 1990, as we already saw in that busy slide, the cruciate retaining the duopatellar process have become PFC sigma CR, and the cruciate sacrificing the total condylar process, Insal Bernstein, has become PFC sigma, PS, Zimmer, LPS now. For years, we have debated which one is better over the other. Still, the jury is out. Both have given consistently good results in the long term. Now, another offshoot of the evolution is mobile bearing versus fixed bearing. And already in the morning, Jagan Mohan has nicely put the slides. Aims to separate rolling and gliding motion of the knee. And again, inflection, femur insert interface, and rotation, the insert is tibial undersurface. So advantage, it's supposed to decrease the stress and wear, excellent survival rates. In fact, I'm a great fan of mobile bearing knees. I do a lot of Bikal Papa's knees, hundreds of them, and they do very well. And if my knee goes, I rather want to have a mobile bearing knee. But long-term results, same, no issues at all. And coming to the medial pivot, another evolution, another interesting concept. There is differential anterior posterior excursion of the medial and lateral femoral condyles during flexion. So the philosophy is medial side, you have to consider the knee joint as a ball and socket, and lateral side, it is just a roll back. And again, one of my favorite joints, I do a lot of right company medial pivot joints, excellent on-table stability, and I'm quite happy and comfortable with that. By the turn of century, let us say by 2000, we have achieved excellent survivorship of implants, and but has this translated into better patient satisfaction? Then the goalpost has changed. The paper has come, the landmark paper, that 20% of the knees people are unsatisfactory, and like a hip, it is not a forgotten joint. 20% of people keep on worrying or bothering or not happy, however good the X-rays look like. So then the concept of the PROMs or patient-related outcome measures have come. And so that's one of the examples. It looks good, but it feels bad. Who cares whether it looks good? And surgeon puts a 9 out of 10 in his personal diary. It all depends on the patient satisfaction. So end of the day, you ask only two questions. Patient, are you happy with the knee? Yes or no? And will you get another knee done, or will you advocate this to your relatives? So that's it, as simple as that. Those two questions will answer the outcomes of the knee replacement success. So again, landmark papers, 10 to 20% dissatisfaction rate, and 1 in every 5 patients is not satisfied with the result. But I feel, I'm sure all my colleagues will agree, in Indian context, the dissatisfaction rate, though we have not documented scientifically or literature-wise, it is lesser than 20%. Because I would feel our people's expectations are less, and they just get on with their life with the new knee. The initial 1 year, 1.5 years, they keep on saying pain here, pain there. But end of the day, most of them are, I would put dissatisfaction rate in Indian context is around 10%, not more than that. But in the Western population, because they demand more, their expectations are more, they want to play golf, they want to do all sexual activities in the 70 plus, 80 plus, and those activities are different. Obviously, when your demands are high, when your expectations are high, your satisfaction rates will be less. So last 20 years, the quest to improve the patient-reported outcomes, that is the important part of the whole discussion. The preoperative patient optimization has become very, very standardized. Gone those days now where you lose a patient postoperatively because of your inability to optimize the patient preoperatively. If you have done that, that means you are not a surgeon, you are a completely callous individual. Refined surgical technique and instrumentation have come, the very, very excellent instrumentation and multimodal pain management. Classical example, my predecessor has spoken so well, the pain management. Because again, in Indian perspective, people have to realize, gone those days where you banish or abandon the patient saying, "Arey, pain to hota hai bhaiya, neppu untundi, edo baku chinna operation pedda operation kada." These sort of things should not be there. Now, pain relief and pain control is an important part which can be expected by the patient and which can be delivered by the surgeon. And multiple new innovations in implant designs, new alignment strategies like kinematic alignment and mechanical alignment, functional alignment, resurgence of unicompartmental arthroplasty. Again, we are the witnesses of this because 5 years I resisted doing a unicondylar, but last 5 years with the advent of my son Adarsh, we went on into Oxford. Now we are doing Mako unis. The results are very good. And the other literature, in fact, coming Saturday, we have one webinar where Chris Dodd from Oxford, Martin Roche from Fort Lauderdale, and Theme Point from Brussels, and Arun Mullaji from India. We are having a ISHK webinar. Please join us. Indian time, 6 o'clock. I'll share the Zoom link with all of you. It's all about unicompartmental arthroplasty. I would urge all the youngsters and the other colleagues to open your thought process or to open the windows of your theaters and think about unicompartment. In a right patient, it is wonderful operation, I'll tell you. And using technology like robotics to better plan and place the implants in the right position. And again, we are the witnessing, we got the 4th generation robotic Mako and a lot of advantages, of course, a lot of advances with that. So coming to the preoperative optimization, decrease of post-op complications. We all know that modifiable host risk factors for PGI in total joint arthroplasty is active infection, alcoholism, cardiovascular disease, chronic obstructive pulmonary disease, depression, diabetes mellitus. In this, all these things which are underlined, which can be modifiable or preoperative optimization. A simple anesthesiologist, like Dr. Ali said, or even a general physician, a fresh MD, if you keep him in your group, he can make wonders. So he will optimize the patients before theater. Resist that this patient has to be on the table tomorrow. No, just let him optimize and then you will get a good results. This is one of the ways we do in our hospitals because with our volumes, we got to get some nice roadmaps so that people can understand. So we got a very earmarked, purpose-built pathways for this, and this will make a wonderful difference. And in fact, our stay is hardly 2 days again. Dr. Ali, we admit the patients right on the day when they go directly to the operating theaters, they won't come the day before, and they go home next day evening or at the most 3rd day morning. So that's what it is. Now coming to the refined surgical technique instrumentation, again, great evolution. Surgical techniques are more refined now because when I started 20 years back in Apollo hospitals, I do not know exactly what is a flexion and extension gap. I'm telling you very frankly. Though I know how to do IB to knee, and I do not know what is exactly flexion extension gap, how do you balance that, what is the most important thing, I don't know. I was still in the learning curve. But now every orthopedic surgeon who is embarking on arthroplasty must have seen 100 webinars, 100 thousands of YouTube videos, because the teaching is at your fingertips. So we have understood the importance of soft tissue handling. Instrumentation has become very, very friendly, and minimal invasive surgery was an overkill that is now past. We're not bothered about that, and cannot pick size of the incision over soft tissue handling. So don't bother about minimal invasive surgery. That was a marketing hype, which has gone to the dust. Now standard techniques is there. Now coming to the, again, the pain management, which already Dr. Ali said, and I don't need to go on this. Excellent evolution in the total journey of arthroplasty. Again, as Ranawat keeps on telling, a patient who has got a less pain in your surgery or in your office will get 10 patients in no time. he will say that this doctor does it such a painless operation. Now, newer implant designs, do they work? This is where I stop a minute and I'll ask you to ponder. Law of diminishing returns. Coming from IB2, the latest implants, I don't need to name the names, the cost-wise, they are 6 times, 7 times costlier, but is the benefit commensurate with the so-called publicity hype and the cost? The answer is definitely no. So basically, we have reached the law of diminishing returns. That means whatever the increment of the benefit we get now will be very minimal. Unlike the 70s and 80s, where there was a leap jump, we cannot do that now because we are already touching the roof. There is only minor space there to go there as far as betterment is concerned. So no doubt we got the multiple sizing options. IB2 was crude, just small, medium, large. But now you got 15 sizes in any personalized knee and gender-specific components, multi-radius versus single radius, highly cross-linked polyethylene, lesion knee restoring the natural joint line with asymmetric implants, bi-cruciate knee saving both ACL, PCL. All these will make any difference? My answer is not particularly. Okay. Then these are the Zimmer Persona, DPO Tune, Smith & Nephew lesion. Wonderful designs, wonderful instrumentation, but will they create such a phenomenal difference in the outcomes? The answer is no. Right, coming to the achieving a kinematic alignment using asymmetric implant design, we all know that Smith & Nephew, they got this kinematic alignment where the implant geometry matches the normal anatomy of the knee. Like that, another bicruciate returning total knee. And 60 to 70% patients undergoing TKR have a competent ACL. So that has given the thought process for the people. But the concerns are it is surgically demanding, cannot dislocate tibia, iatrogenic ACL injury, and ACL bone island fractures. But no, slowly it is gaining momentum. The next plan will be having a bicruciate returning TKR. The simple logic or rationale behind this is, why don't you hang on to the natural knee kinematics? Because they think that the so-called 20% of the unhappy knees might be because of this violation of the natural knee kinematics. So basically, now we are going almost opposite road of Insal and Ranawat, where they say the knee need not be natural to be functional. So this is the bicruciate knee, closely mimic natural knee kinematics. So now what is in, what is out? In my 20 years of practice, what all I have learned from the personal perspective, minimally invasive surgery, out, patient-specific instrumentation, out, high flex design, gender-specific knee, out, high flex design, again, plus and minus, and there is no paper and no way you can prove that a purpose-built high flex knee or designed or advertised high flex knee will give a high flexion than other knees. No, we can get high flexion even with the normal knees, with IB2s, the first PFCs, Zimmers also gave excellent knee flexion depending on the surgical technique. High performance personalized knee, again, a load of rubbish. So implant materials, titanium nitride coated cobalt chrome, oxidized zirconium. Okay, some people say they are good for the people who got allergy to the cobalt chrome and nickel. How many people you have come across in your practice, so-called cobalt chrome allergy? Hardly any. But anyway, they won't harm anything. So if you got any issues with the so-called allergy, you can put oxidized zirconium or oxynium joints, no problem. Highly cross-linked polyethylene, again, it has not made such a dramatic impact as it has done in the hip replacements. No doubt, the cross-linked polyethylene has become a standard in knee replacements, but it has not done that such dramatic improvement like it did in the hip replacements. Vitamin E, theoretically, scientifically, it looks very attractive because it just cleans up all the so-called debris of the polyethylene in the sort of molecules. And whether it translates into functional and outcomes, I don't know. Computer navigation, again, it has reduced the number of outliers, but this has not translated into better outcomes, but it has helped people, including me, to improve our practice by some marketing. So what have I learned from my experience? End of the day, I would say perfect mechanical access restoration is also not that important. 2 degrees varus valgus is highly acceptable. A paper has come from Mayo Clinic. In fact, we are doing now our own 10 to 15 years review of the knee replacements. where the mechanical axis is haywire, 5 degrees outliers, but functionally they are very good. So problem due to joint elevation is overrated. Of course, you cannot put a knee joint at a hip level, but 5 millimeters that way, this way is not going to make any difference. And knee flexion is not design specific. These are my personal observations. Anterior knee pain following non-resurfacing patella is a myth as far as I am concerned. I have not touched the patella in my last 10,000 cases. All of you who worked with you know that. You have never seen a patella in my place. CR or PS design is a surgeon's choice. Again, like whether you are a Catholic or Protestant, no difference in functional outcome. I would feel in my last 20 years, after many thousands of knees, personally, if you ask me, what is the single most important parameter is balancing the knee flexion extension gaps during the surgery. And our infection rate in a standard hospital setting is also comparable to Western standards. No, you don't need to be apologetic and you don't need to accept the Western guy saying your infection rates are sky high. No, it's a load of misplaced rubbish. Our infection rates in all the hospitals where the joint replacement, let me say 50 per month average. On those hospitals, the infection rates are as good as any Western population. So advances in arthroplasty, which I think will make a difference in the future. Role of robotics. Yes, I'm with the robotics, but again, people, if you ask me frankly, or what you call very, very open statement, robotic is not mandatory for your knee replacement for good outcomes. But it might help you in the future with the big data and the artificial intelligence, because I would see a future in the, I don't know whether it will, I think probably before I disappear from this world, I would see a robot will tell me a 30 degrees, like Ramana showed the 45 degrees to 80 degrees flexion deformity knee. The robot will tell pre-operatively, look, young man, you got to go here, cut 8 millimeters of femur here, and go to the MCL, stop here. And now you go to the pie crusting, do the 7 pie crusts on the popliteus. And now you go to the posterior popliteus fossa. Look, there is a popliteal artery next to you. The red light is there, stop there. Like that, a robot will give you a beautiful path with the help of the big data and predictive analytics and artificial intelligence in less than 5 to 10 years. That is my prediction. Because with the data, 10,000 permutations and combinations of a knee replacement can be fed into the robot, and which will tell you. It is no way you can surpass that robot. Role of resurgence of unicompartmental knee. Again, I've become a great fan of the unicompartmental knee. Excellent results. People walk on the same day and they're so happy because it looks like a natural knee. And in fact, we are now doing a paper, and to your surprise, we have done a paper. We have opened 4,000 knee replacements and taken a photographs of the ability or amenability of the that knee to unicondylar according to Oxford criteria, like ACL intact, the only anteromedial osteoarthritis. To our surprise, 35 to 40% of the knee replacements which we are doing now are amenable for unicompartment arthroplasty. So I would feel that 20% of so-called unsatisfied knees may be better served with a unicompartmental knee. In other words, we are doing a wrong operation for a right indication. That's my thought process. Future will tell. But unicompartmental knee has got a role in every surgeon's armamentarium, provided you pick up the right patients. And newer alignment strategies like kinematic alignment, functional alignment, again, they are challenging our so-called comfortable thought process, which we have been in the last 20 years, thanks to Insal and Ranawat. We stood there at mechanical alignment, but the kinematic alignment, functional alignment are changing the perspective. And thanks to the robotics, we are able to see. In fact, we are doing one paper where on one side, we are doing a simple mechanical alignment with robot. Second side, we are doing a robotic assisted kinematic alignment. And let us see which is better. Cementless fixation, though it is not coming into India, but it will come in a selective patients. Cementless fixation has got a tremendous results, as good or even better than the cemented knee replacements. Orthosensor technology, again, another thing. Big data, we already showed you on that. Now, orthopedics, as we said, we got this robotic center, and we are now happy to share with you, with a matter of fulfillment and pride, that we have done the first 200 robotic replacements in less than 2 months of the working days, the fastest in the world. This is not boosted by me, it is given by the global platform, by the Stryker and Mako, the fastest in the world, the robotic knee replacements. we are happy to share that with you guys. And coming to the robotics, again, as I said, no robot doesn't what you call operate. It only assists you to do the surgery, and it is not imperative or mandatory. But I would feel, again, in the future, next 10 years, robot will become like a CR for doing, because a lot of the times, if you see, forget about the marketing hype and all that stuff, see the logistics, a lot of the time still we eyeball or use our experience in knee and hip replacements. Why should we do that? We don't eyeball when we drive an aeroplane or drive a car. So just like that, probably robotics will change that. And object-wise, for example, here you can see that tremendous sizing. You don't need to do any notching or anything. You know where the osteophyte is, and you can do the precision cuts. I'm not here to sell the robotics. I'm just pondering on the plus points, whether you have to spend bloody 10 crores or $1 million for this robotic to achieve this. The answer is no. So, but you got to aim these things, and these will probably add that or reduce that so-called 20% unsatisfied people. So again, the beauty in this robotics is your customized CT scan. You are absolutely 0.5 millimeters close to your normal anatomy, so that you can do better with the robotics. And again, another important thing is haptics. Haptic control has come, and papers have come. With this, the soft tissue damage on the peri-tibial side, that means your saw blade going and cutting the other parts of the knee, cannot happen, because the moment it crosses that green line, the robot will not let you go. So this haptic boundary is again another important advance in the robotic technology. So whatever is that, the consistency, the reproducibility, every single time, that is the point, take-home point for the robotics. So we can do that. So let us go through this one is, as I said, mechanical access, kinematic alignment, so which we can do that. So these are all about the things. And unicompartmental knee, again, as I said, I was skeptic in the first 5 years, but now with the anteromedial osteoarthritis, first case and 100th case, we have the same accuracy, so we can do that. Now, cementless fixation, it holds promise. And why can't we replicate the success of the total hip arthroplasty in the total knee? Definitely, I think it will be a good option in less than 50 years, highly active patient. And in fact, if you go to the literature, Striker Triathlon has got a more than 15 years cementless data, excellent data. This is the orthosensor technology. Again, you got the, it helps the soft tissue releases and balance the knee properly, and it inbuilt in the polyethylene. So huge amount of data is being collected through robotics. Large centers like Sunshine are adding to the data pool. In fact, we are one of the 10 centers globally selected to give our data to the international data pool. And with the help of big data and predictive analytics, I'm sure we will raise to this occasion where we can get 100% success, not 99% success out of the knee replacement surgery. Thanks for listening. And it's a great pleasure and privilege to be with all of you guys. Right,
Thank you so much, sir.
Yeah.
That was a wonderful talk.
Yeah, I'll stop sharing. Right. So now we are open for discussions. Yeah.
Yes. I'd like to ask Somashekar Reddy sir to chair the panel discussion. Sir, you're not audible.
We had good talks and also like a good representation of how a recorded presentation works for these sort of the meetings. For the next meetings, this is like a trial run, the last 2 meetings. So yeah, pre-recorded, they do work and less waste of time. And for example, Uday got some issues playing his videos, but Gurvi has played his makeup video very well. So yeah, I mean, so these are things to not just the subject, but the practical aspects, because we are now more and more depending on this technology, remote presentations. So yeah, we do need to get our hands on this one and make it more useful. Yeah, the idea is about this meeting is to actually addressing postgraduates and young surgeons, and I think that purpose has served well. We have not really looked into very complicated cases or complex treatments, complex replacements in this one. But having said that, when the pain control should be like everyone's cup of tea. I mean, we can't neglect pain control. And I thank Dr. Ali for that one. With that one, yeah, Srinivas, any words?
There are a few questions, sir. Just let me start with, we'll have a couple of questions and then end. Of course, the time is already up. It is 12:28. We'll at least have 15 minutes of discussion and then close. Is that okay? If it is okay with everyone?
Yeah, sure, man. Come on,
Yeah.
get up.
Okay.
Some discussion should be there.
Yeah.
Before lunch.
Yeah, yes, sir. So what Uday was talking about tranexamic acid, and I just wanted to ask all the panelists. So, what is the role and how do you use it in your practice?
Yeah, tranexamic acid is one of the best things that happened to the knee arthroplasty in the last decade. And paper after paper across all parts of the world have convincingly proved. In fact, we also produced 2 papers. So tranexamic acid, how to use, whether it's a topical or systemic, it doesn't make a difference. But definitely it is a game changer, especially for people like Ali who wants to send the patient same day. That has made a tremendous difference. I don't use the drains for the last almost 5 years.
Yeah. Any inputs, Dr. Ali?
Yes, I mean, in our practice as well, tranexamic acid has been a game changer. It reduces bleeding. We sometimes give a supplementary dose for prolonged procedures. So one dose isn't necessarily all that you give. Typically in a knee replacement, like I said, we give our tranexamic acid just before the tourniquet is let down. So I let down the tourniquet and you can actually see the difference right in front of your eyes. Patient starts to have reactive hyperemia, bleeding, but then the tranexamic acid takes a couple of minutes to kick in and then it becomes a blood clot. One small note of caution, when you're using tranexamic acid, I would recommend that we complete the washout as quickly as possible. I'm not saying that we should compromise on the quality of washout or the quantity of fluid used, but it needs to be achieved in a timely manner. So when you've controlled the active bleeders, you wash out the excess blood so that the tranexamic acid forms the clot, and it's important to maintain the clot. You do not lose the clot. What I mean is, not the big sort of hematoma clot, but a sort of thin layer of blood clot that forms after giving the tranexamic acid.
Is that after local administration?
No, we give systemic tranexamic acid.
Yeah, we
Can I add something here? Yeah. So in our center, we used to give tranexamic acid systemic intravenous 15 minutes before the release of tourniquet. But now we have switched on to local injections. Once you close all the wound before the tourniquet is released, we inject 3 grams of tranexamic acid into the joint and then release the tourniquet after 10 minutes. This has worked wonders. Our average blood loss, which is between 250 to 300 ml, has come down to 50 to 70 ml approximately, and we have stopped using drain because of this.
Dr. J.V. Srinivas, so don't you use systemic tranexite?
No, not at all. 3 grams of
only
local injection into the joint, that is the only thing we are using. Because again, some reports are saying that patients having cardiac issues may have side effects on the cardiac because of systemic use of tranexamic acid. So we are using local, injecting into the joint before we release the tourniquet.
Yeah, Uday.
Yeah, Srinivas, as the pioneer of bilateral knee, Dr. Gurareddy sir, because we in our institute also we do the bilateral, but after the advent of the tranexamic acid, definitely in bilaterals also there is a drastic reduction in blood transfusion. Now, of course, because of the other issues, we reduce the bilaterals, but using a bilateral also it helps in reduction of this one. I use the systemic, I've switched on to systemic rather than giving intraarticular because of other comorbid conditions. I think it works very well.
I agree with you. Bilaterals also it can be safely done without any transfusion because of the tranexamic acid.
So another question to Dr. J.V. Srinivas, you were talking about pie crusting and extensive release on medial side. When do you do extensive release, that is superficial ligament, pie crusting? Which one
See,
first?
see, most of the time we all do a minimum release with deep MCL, which is released and the capsule to the posteromedial corner. 9 out of 10 times deformity is corrected. Very, very, very rarely we used to release the superficial MCL, and now off late it is completely stopped, because just doing a pie crusting, most of your deformity is corrected. Most of your deformity is corrected. You need not release a superficial MCL. The day when you release a superficial MCL, then you need to have a constraint implant inside. I'm sure moment you release the superficial MCL, the whole knee opens up on the medial side, then you will be in trouble. So we have stopped releasing superficial MCL. We release deep MCL, we release the capsule. In case your deformity is still not corrected, just do a pie crusting of superficial MCL. That should be enough.
Thank you so much. So any other inputs on this?
I beg to differ with Srinivas. Pie crusting is not such a simple task. Sometimes it can create disasters. So a standard, calibrated, titrated release of the superficial MCL from the tibial attachment is a 50-year-old concept done across thousands and millions of knees with excellent results. So I beg to differ with Srinivas. With Srinivas' experience, pie crusting might be okay, but not for every surgeon. Pie crusting is a dangerous thing, Srinivas.
Sir, I want to add here.
Yeah.
Your pie crusting will not do with 11 blade. 11 blade you do, as you said, it's a disastrous. 11 blade.
Yeah.
You only use a 16 gauge needle, multiple in holes on that.
Multiple punctures.
Yes, that's all.
I agree.
As you said,
Yeah.
11 blade, as you said, we'll have a disaster. As you said, rightly you said, it's a disaster. Only 16 gauge needle and multiple holes into that MCL would be suffice for the surgery, sir.
Yeah, that should be all right.
The common question which was asked is preoperative antibiotic. What is your preferred preoperative antibiotic? This question is for everyone. We'll start with Guru Reddy, sir.
The same old antibiotics, nothing changed. Second generation cephalosporins, 3 doses, 1 preoperative, second 6 hours post-op, third is 12 hours post-op. Since I was in England, last 30 years, the same second generation cephalosporins. Some people are giving 1 shot, but I have not gone to that. But if any one of us, I'm telling you guys, the panel, starting from all the people, the young postgraduates who are embarking on the journey, if they are giving more than 3 doses of antibiotics, that means they are not practicing arthroplasty. They are practicing third grade, let me tell you, science. So if you are putting more than 3 antibiotics, that is to treat you, not to treat the patient.
I would fully agree with Gurava Reddy, sir. As I was alluding in my talk earlier as well, I think the recommendation as per any guideline you say is that the timing of the antibiotic administration is very important. It has to be within half an hour of your incision or maximum 1 hour. And the dose again depends on the patient's age and comorbid conditions, but second generation cephalosporin is the gold standard, I think. If the patient is allergic to any of the cephalosporins, then you may consider giving clindamycin or vancomycin. And if most primaries may not extend beyond that, but if the surgery is getting prolonged beyond 4 hours, then a second dose of antibiotic may have to be given intraoperatively in case of complex revisions or a prolonged surgery. But I guess that should never happen in case of a primary replacement. And there is no role for any extended antibiotic prophylaxis beyond the first 24 hours. That is period. Because this is a clean surgery and you have to optimize the general condition of the patient, and it has to be done under a right theater environment. And any extended prophylaxis beyond 24 hours is only increase the chances of developing antibiotic resistance.
Yeah, I would like to come in on this. Thank you very much, Dr. Guruvareddy and Dr. Chandrasekhar. I think, again, a key message to go out to patients and to people practicing knee surgery is that, yes, extended antibiotic prophylaxis does increase antibiotic resistance. And in elderly patients, it could potentially, when you're using cefuroxime, cause C. diff, diarrhea or necrotizing colitis. In our practice over here, MRSA is a very important consideration. I'm not entirely sure whether MRSA is an issue in India. So patients are...
Not that much, Charlie.
Not much of an issue, okay. But we also have an issue with methicillin-sensitive Staph aureus. So Staph aureus is by far the commonest bug that we have causing an infection. So we routinely practice decolonization, not just for patients who have MRSA, but for patients who have had positive swabs of methicillin-sensitive antibiotics. In any case, patients who come into hospital on the day of surgery, they will still have to have a chlorhexidine shower. We are giving patients decolonizing soaps, chlorhexidine soaps to use for 3 or 4 days before surgery. So, I mean, these sort of things are important, but also I think it's very important for everyone to understand, like Chandrasekhar pointed out, that laminar flow environments are absolutely critical for doing knee replacements, and the use of antibiotic-loaded cement, absolutely critical there as well.
And another simple thing I think the youngsters should realize is, Srinivas, more than the laminar airflow, of course, that is very important. Do not shave the leg 24 hours before. Clip the hair in the theater. That itself is again a game changer. Because previously we used to shave it, put it in a batter in this thing. No, clip it, not even shave it. Clippers are there, very cheap. Clip the hair just before the surgery. Again, important point. And again, as Ali said, chlorhexidine pre-op preparation is much better than betadine.
Yeah, but also a full body shower is absolutely an essential for us. And another thing I'd like to ask the panel is skin breakages. Now, increasingly in the UK, patients with skin breakages, with ulcers, with scratches, or with small, if you like, boils, we are cancelling on the day of surgery. Before the operation, we counsel the patient that if they have any problem with the skin, it has to be treated, whether it's eczema, whether it's a small ulcer, whether it's cuts. We have a zero tolerance policy, absolutely. We do not operate on legs or patients who have any wounds, any scratches or skin problems at all.
I mean,
so that has to be sort of put forward to the patient.
A different part of the body or related to the same leg?
Anywhere, any potential source of infection, particularly in that leg, of course, but any source of infection, any source of cuts, bruises, we are not operating on those patients. We're telling them to take good care of their skin. It sends the message as well that they have to take good care of it.
Another important point which I found in the pre-op optimization, I think again the youngsters should take a leaf out of it, is optimization of the nutrition. We underestimate the importance of nutrition, especially albumin, and especially our people, a lot of vegans are there, vegetarian ladies are there. And these people, the that nutritional status will create a wound problems. And not only that, the so-called myalgia, the post-op people having the muscle pains, thigh pains, leg pains, all of them can be well dealt with a nice 6 weeks to 8 weeks, if possible, of nutritional enhancement. So that is again a point which we are not understood or not given enough emphasis so far. I think we should harp on that again. One more point.
Yeah, well, I might remember American surgeon actually sending two lectures on nutrition. Uday, you know the name.
Yeah, because the pre-op optimization, as sir was mentioning, 6 to 8 weeks, there are a lot of papers like hypoalbuminemia less than 3.5 is 3 times the risk of periprosthetic infection. Absolutely. 3 times risk of periprosthetic infection.
These are all manageable.
Yeah, these are all correctable, manageable.
These are all manageable. So you got to do that.
Yeah, regarding the one more point in the antibiotic thing, like anyway, we use the same protocol as others have mentioned. I also add antibiotic loaded cement for primary complex knee arthroplasty because extensive release, it will have more time and more thing. What about your take others, whatever the suggestion?
I used to routinely do antibiotic treatment for all my knees in the past, but for the last 2 years, we were not doing anything at all. No antibiotic cement, except for the revisions.
Again, the guidelines from the American Academy of Orthopedic Surgeons, it does not advocate routine usage of antibiotic-loaded cement in cases of primary replacements.
In the primary complex.
Yeah. In case of revision surgery, suppose you are doing a primary complex, perhaps you are doing an extensive surgery, or if you are doubtful about the infectious status of the knee, then yes, I think usage in those selective cases may be advocated, but not as a routine practice.
Yeah.
Another question. There is a controversy between Dr. J.V. Srinivas' talk and Dr. Ramana's talk. We want some clarity. So in FFT, anterior reference and upsize is the first step which J.V. Srinivas want to take. Upsize the femur. Whereas direct 2 mm extra cut by Ramana. So what is your take? We'll start with J.V. Srinivas and then ask other panelists.
Hello?
Hello. Can you, have you got the question, sir?
Yeah, I got this. See what happened.
Why you are not on video so far? You were sleeping, my friend?
No, sir, I was listening to you. Now, see, when we are doing a severe flexion deformity, especially in rheumatoid arthritis, so getting correction is not that easy. So, as Dr. Ramana said, you go on increasing the tibial cut. We don't want to cut the femur. Reason being, you're pushing your joint line up. Eventually, after 4 millimeters, if you increase your distal femoral cut, your joint line has gone up and you'll end up with mid-flexion instability. So you cut your tibia. Moment you cut your tibia and you flex it, your joint space in flexion, that is your flexion space, increases drastically. So to be on the safer side, you anterior referencing, have a big femur, compensate your flexion space, which is going to increase by cutting the tibia. If you feel your flexion space is tight, then you come back to the normal size. Always having an upsize, and you can come down later. But if you straight away use a 2 millimeter up and use a normal size, then you'll end up having a severe flexion instability. That's why, that is the concept. That's all.
Is Ramana there?
Ramana had a video session only, sir.
All right, okay. So I think my take is, I think, okay, let Ali talk. I'll talk afterwards.
I think, well, I'll let you continue, sir. I'll join in after. It's okay. I just wanted to make an additional point.
Please go ahead. Go ahead.
Well, I just wanted to say to the younger amongst the audience that anything that is complex, they should consider having somebody senior with them before embarking on that sort of surgery. It takes a lot of experience to make that judgment about how much to resect and what releases to do. So my advice to the younger amongst the audience would be start with simple knees, but if there's something very complex, they should do it with someone, or if they do not have access to someone, they should refer it on. They should be very honest rather than have one very bad result that could affect their reputation. They'd be better off losing one patient and gaining a lot more.
Yeah, you're absolutely spot on, Ali. But thankfully now the arthroplasty surgeons are dime a dozen. And so any young surgeon, if he has got an open mind, there will be 100 Gurva Reddys, 100 Srinivases, 100 Somsekhar Reddys available within half an hour distance, within half an hour. Even on the table, if he is stuck, another surgeon can come and bail out. So many surgeons are there. So the only thing is he should have an open mind. Coming to this debate about the FFD, I fully agree with Srinivas. Upsizing has got a much scientific validity of dangling with a bigger flexion gap vis-a-vis extension gap. But I would routinely do, Ramana learned from me, I would routinely cut extra 2 to 4 millimeters of the femur. My argument is 90 out of 100 knees where I have to revisit the femur. So I thought, why not you cut it in the first thing? Number two, over the years, I learned some of the concepts of this elevated joint line is a theoretical overhype. That from my personal perspective, no doubt I have burned my fingers of mid-flexion instability, but elevating the joint by 4 millimeters in a fixed flexion deformity by cutting the extra femur, I have not come across. It is a theoretical, every time they keep on quoting, but it won't happen. But I agree with Srinivas fully. The oversizing of the femur is a much more idiot-proof methodology of tackling the flexion deformity. But cutting extra 2 to 4 millimeter distal femur doesn't create any problems.
Right. Any other inputs on this?
But flexion deformity, you should be brave enough to do a capsulectomy or how should I put it? A diathermy. Ranawat described it, and he has shown the video hundreds of times. You flex the knee, put a laminar spreader, take a diathermy, start from the PCL, go lateral right up to the popliteus, and erase the capsule at the tibial cut. And that will open the space. That is a very, very important step. A lot of us get scared, but once you start doing it, you'll be all right. Don't cut it with a knife, cut it with the diathermy, because the moment the diathermy goes to the common peroneal, and you know that, Are bhai, be careful.
Yeah. So, thank you.
Yeah, we learned from the masters where we trained either with Dr. Groyde sir or with Vikram Shah in the Shelby. If you are not a knee replacement, unless until you touch the posterior capsule, you should be dare enough to remove all the nicely in especially in the complex knee to nicely use a broad osteotome or blunt osteotome slowly to release the posterior medial release up to medial head of the gastroc, so that before embarking into direct cut of the distal femur.
So there is one question. This is actually my personal experience, sir. Usually we get a lot of cases operated elsewhere, but got admitted into ICU in a medical kind of so under a medical person, let it be a neurophysician or a general physician for various other reasons. And once they are in ICU, they land up in fixed flexion deformity. They used to walk very well after surgery, but after prolonged ICU stay, their knees goes into FFD. How to deal with it? Any experience?
Simple. You got to first of all develop a mechanism to warn the patient for at least 1 year after the operation. That is where we falter. We say, out of the sight, out of mind. Some complication comes, let him go to somebody else. It doesn't come to me. No, you should warn the patient. So you should develop a mechanism where your secretary has got the numbers, and the patient relatives and patients should know that wherever they admit in that city, they should intimate you. That is your fundamental moral obligation. A lot of us think the otherwise. No, let us shun him out. And second point is, the moment, suppose if he is admitted in the same hospital in the ICU, you just go there, tell the ICU guys and put him on a leg splint, extension splint. And every day the physiotherapy should come, open the splint. Otherwise, there will be a lot of pressure source. Again, I have seen that happening. So physiotherapy should come, open this, and then take care. And your registrar should visit this patient every day. So that is warning the patient for 1 year will give a lot of satisfaction to the patient and to you also. Okay, 1 in 10 will be a nuisance. They will keep on bothering you, but so be it. That's a part of life.
Thank you, sir. So the question. Meanwhile, any more questions you can discuss, sir?
One question to Dr. Ali.
Yes, Dr. Uday.
Yeah. The thing is, like, as you mentioned in the first slide of the video, you've shown that the hip replacement lady was going to discharge on the same day. She's around 75 or 80. Is the approach matter for you for discharge? Because the anterior DA approach, without any soft tissue cutting, we discharge on the same day. But the posterior capsule, whatever the posterior approach, there is a lot of soft tissue dissection. Do you still discharge on the same day, these patients?
I'd like to clarify that patient was discharged on day 3. She wasn't the same day.
She was walking on the same day. That's what I
walking on the same day. And regards walking on the same day, even patients who have had posterior approaches, we do not put restrictions anymore. There has been extensive work done again by Mike Reed, Paul Partington in Northumbria Foundation Trust. They have published some work, and they've looked at unrestricted mobilization for patients who've had posterior approaches, and the dislocation rate is not any higher. So, but regards day surgery hip replacements, I would like to share a video if you want. I mean, I can show you a video of another hospital very close to ours that was covered in the BBC. I'm happy to put the link in the chat box or show the video. They did day surgery hip replacements, but in younger people. In younger people, as we all know, the muscle mass is very good. The tension you get in the hip is very good. So potentially day surgery, total hip replacement through a posterior approach is very feasible.
Yeah, thank you.
Srinivas?
Yeah. Sure, sir. So, to conclude about the panel discussion, the points covered and the message take home is, so optimization of the patient, which is most important, especially not only medication wise, but also nutrition wise. That is one point which was very apt and important. And antibiotic, only 3 doses for all arthroplasty. And pie crusting, be careful, use a smaller thing. If you have experience, do that. Otherwise, take somebody's help. As Guru Reddy told.
All Srinivas from Bangalore.
Not intraoperative from the beginning, yes, sir. And own a patient for at least a year. I would say forever, not at least a year.
Forever. Yeah.
So that they inform you at least if they get admitted anywhere else in this thing, and we have a moral obligation to address them at least by calling the treating doctor. With this, I would like to thank all the speakers. Sir, Somashekar Reddy, sir.
No, that's fine. So all went well, and we are Guru, like as you know, we are trying to continue the TCOS tradition.
Yeah, good.
And so far, Srinivas has been very active on this one, and we are continuing to hold the flag, TCOS flag up.
Yeah, you're doing good work. I'm guilty of my lack of participation in the TCOS for various reasons.
It's okay. It's mainly like, as you know, to a certain level, but as and when we need experts, we are calling anyway.
Not only that, any other help, I'm always there.
Yeah. Sure.
One help,
one help information.
We'll take this opportunity to ask Guru Reddy, sir. One help, ask your people to participate, sir.
Oh, it's definitely. I'll see that.
That is only help, even during
DNBs. I'll see that they all attend the programs next time.
Yes.
And Dr. Ali might have known that while he was still in Hyderabad, this TCOS got started by Professor A.S. Rao in 1986 with the monthly Sunday meetings, every month Sunday meetings, and interns, Usmania, Gandhi, NIMS, then Apollo, KIMS, and Kauneni, like every month. So any year, each hospital gets 2 turns, and they are responsible to organize that month. And that tradition, our seniors have started, and we are trying to continue.
It was a very fine meeting. I thoroughly enjoyed it. That was my CME of knee replacements for the year done. Excellent meeting.
Ali, thank you so much. You added a nice.
Thank you.
I love it.
It was a real privilege getting to meet you all and listen to some excellent presentations. And I would like to say to the younger audience as well that, they've got to be really proud that they've got tutors like yourself. Always happy myself to be a part of this group. Thank you very much.
Thank you, sir. Thank you all.
Okay, thank you.
Signing.
Thank you. Bye-bye.